Mm. Hello and good evening to everyone. So today is our third day of this infertility certification course by ICOG and FOGSI. And to welcome us and to everyone, we have Dr. Sarita Bhalerao Madam. She is an obstetrician and gynecologist at Bhatia Saifi Reliance Foundation Hospital and Breach Candy Hospital, Mumbai. She is the dynamic secretary of ICOG, very humble, very down to earth, and yet she knows how to get the work done. She is the chair of the W Western Zone India Representative Committee of RCOG. She has been the past secretary of Indian Menopause Society Mumbai chapter, president of Mumbai OBGY Society 21-22, joint secretary of FOGSI 2017, and quiz committee chair 2009 to 2011. So, yes, so we are here to hear your welcome note, Dr. Sarita Bhalerao, madam, and the stage is yours. Thank you.
Thank you very much, Dr. Minu, for that kind introduction. Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome you to this last and final day of our certificate course in infertility. We have had an excellent last 2 days, and I'm sure that today will be as good or even better. I'd like to thank our President FOGSI, Dr. Jaideep Tank, and Secretary General Dr. Madhuri Patel for giving ICOG this opportunity to do this course. I'd like to thank our ICOG Chair, Dr. Parul Kotawala, our Dr. Office Bearers, Dr. Sheila Mane, Dr. Lakshmi, Dr. Parag, and Dr. Ashok Kumar. Our series conveners, Dr. Sheila Mane, Dr. Parag Biniwale, and Dr. Charmila. A big thank you to our conveners, starting with Dr. Minu Agarwal, Dr. Madhuri Patel, and Dr. Fessy Lewis. They've done an excellent job. And really, I know the kind of effort that Dr. Minu Agarwal has put in. Thank you so much for really doing this job. So it's nice to have new faces, and we have 3 coordinators, Dr. Shrishti, Dr. Samida, and Dr. Sandhya, and they've done an excellent job. So that's lovely to have them. As part of my welcome, I'd like to invite all of you for the ICOG conference in 2024. It's going to be on the 18th to the 20th of October at Ahmedabad, and the free papers are submissions are on. You can do that. I also invite all of you to become members and become fellows of the ICOG. This year we have 2 convocations, one in October in Ahmedabad and another one in January. For all this and more, you can log on to icogonline.org for all the information. And I'm going to put that in the chat box just so that you can quickly photograph it and keep it. And whenever you get time, do go to the website. Thank you very much and wish you all the very best for this evening.
Thank you very much, Dr. Sarita Bhalerao. And it was great to have you welcome everyone. I've been waiting for this for the last 2 days. So now we also for you have 10 ICOG points. You are attending this 3 days meeting. Welcome, Fessy sir. Thank you for joining. So we have
I
3
think maybe Dr. Parag would like to say something.
Yes,
Parag?
I will introduce you. He's the chief guest today. So you also get 10 ICOG points, and you can log in to the website and get the recorded 3 days if you want to revise after a week. So with that, now Nilima, can you share Dr. Parag Biniwale's CV, please?
Miro, don't waste time in reading it.
No.
We'll have more time for scientific deliberations.
So Dr. Parag Biniwale, the very handsome and the pride of Pune, I can say, and of course, very pleasant personality, very down to earth, and very approachable. And you can call him anytime. Good friend. He's a senior consultant OBGY from Pune. He is the PG teacher and unit head at Kamla Nehru Hospital. He's chairperson elect ICOG 2024. He has been the president of Pune OBGY Society last year. Vice chairperson.
Thank you, Meenu, that's it. Thank
Okay,
you.
all right.
So,
Okay, okay. He has contributed many articles, and I should tell you this, that as a president of Pune OBGY Society, he started so many new things which we are still carrying on. In every president is carrying on in his or her tenure. So thank you for that vision, Parag. Thank you.
thank you, Meenu, for those kind words. You are always generous in introducing me. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be uh, talking to you once again on the third and final day of this certification course. And I must uh, compliment the three conveners, our governing council member, Dr. FOGSI Lewis, Dr. Meenu Agarwal, who has put in a lot of effort, and of course, Dr. Madhuri Patil, who was a governing council member with us earlier. Uh, also would like to appreciate the three young stars of tomorrow, I should say, Srishti, uh, Samida, and today Sandhya. Sandhya and Samida are new stars from Pune, and they are doing excellent work in the field of fertility as well as in Pune OBGY Society. I appreciate all the delegates joining these courses because the ICOG courses are meant for all FOGSI members and even non-members, but only FOGSI members are eligible to receive certificate. Only FOGSI members are eligible to receive the ICOG credit points. And mind well, these ICOG credit points will be useful when you wish to become a fellow of ICOG. As Dr. Sarita, the Secretary of ICOG, has said, do visit ICOG website. A lot of activities are already going on. A lot of activities are forthcoming. This is basically a platform for academic exchange, and please utilize the expertise of all faculty who are going to do deliberations today. So once again, thank you all for joining, and my best wishes for the program. Thank you, Bill.
Yes, thank you, Parag. Thank you for this chief guest blessings and your address. So now we will have Dr. FOGSI Lewis, sir. Are you there? Yeah. So we had this, today is the third day. I know you were traveling, so you were not able to join yesterday. So shall I recapitulate yesterday's program?
Yes, Meenu, please go ahead.
Okay. So, FOGSI sir, yesterday we had a very good session. We started with a PRP and stem cell rejuvenation of the ovaries by Dr. Nalini Mahajan. She came forth with a lot of evidence and lot of also the critical points in using PRP and stem cells for the ovarian rejuvenation. Then we had Dr. Naina Patel, the queen of surrogacy, and she also actually explained every small and everything about surrogacy, the new law, where we stand today, and how we should go ahead with it in case somebody wants to register as a surrogacy clinic. Dr. Sunil Jindal, अपने अंदाज में, he spoke very nicely about the paternal aging, and we also do understand that the age of the male factor does matter in spite of having a normal sperm count. Then we had Dr. Rishma Dhillon-Pai, who she spoke about very difficult topic, recurrent implantation failure, the uterine factors, how the hysteroscopy might help in a few cases, and what else we can do for the uterine factors in recurrent implantation failure. Followed by Dr. Priya Kanan, she spoke about the embryonic causes of recurrent implantation failure, whether we need to really subject every embryo to pre-genetic testing, or there are possibilities that morphologically good embryos are actually genetically good embryos to get implanted. Then we have a case-based discussion on the use of adjuvants in ART, which was very nicely taken by Dr. Nilesh Palkavade from Pune. And he discussed, it was just case-based discussion. So he discussed it very nicely again about the role of adjuvants, both in male infertility and in female infertility, or also for the couple. So this was all that we covered on day 2. Day 1, we covered all the basics, and today is day 3, where we are trying to take more of insulin resistance, whether we need to do hysteroscopy for everyone, how to give the luteal phase support, and how what to do if the follicles are not equal in size, they are asynchronous, and also how to manage the hyper responders, the newer protocols of down regulation and individualized again luteal phase support, and what we should know about the new ART bill, what everybody should know, what they can do, what they cannot do. So all this that will be covered today. Can we post the pre-test now, Nilima?
Yes, ma'am. Jignesh?
So we are posting the pre-test. So you get about 10 minutes to do that. And once that is finished, then we will start with our first session on pre-IVF strategies in ART. Is it necessary? Uh,
He joined. First speaker is on.
Okay. So Nilima, we got from everyone.
Yes, ma'am.
Okay. Thank you. Jignesh, you are doing the coordination today, है ना?
Yes, ma'am.
From ICOG. Great. So let us have now go ahead for the first session. And the first session is pre-IVF strategies in assisted reproductive technology. Is it necessary? So I would like to introduce the chairpersons for the first session. Can you display the CVs, please? FOGSI sir ka CV. Jignesh, can you please share the CVs?
Yes, ma'am. Poonam is doing. Just a second.
Okay. So it's a great privilege and an honor to introduce Dr. FOGSI Lewis sir here to this audience. I think everybody knows him. He does not need any introduction to the FOGSI crowd in India. He's in the Department of Reproductive Medicine and Surgery at AIMS Institute of Medical Sciences, Cochin, Kerala. He has been FOGSI Vice President 2021, ISAR National Executive Member, Vice Chairperson of Kerala Chapter IHGE, ICOG Governing Council Member
It's okay.
21-22.
Short of
Sir has been the All India International Academic Exchange Committee chairperson. So he did a lot of work during that time, and he has also been very, very active in the Kerala chapter of various organizations and in the Kerala Society, and very humble and very nice to talk to. Whenever you call him, he'll always pick up the phone. So thank you very much, sir, for being here, chairing this session. And he's a part of our team as one of the conveners for the entire 3 days infertility course. So thank you very much for that, sir. Sandhya, can you introduce the next chairperson, please? Sandhya, can you introduce the next?
Hello everyone. Yes, so the next chairperson for the session is Dr. Sarita Bhalerao. She needs no introduction because she's with us since 3 days already. But for the formal introduction, she's she's an obstetrician gynecologist working in Bhatia Saifi Reliance Foundation Hospital. She is the past chapter secretary Indian Menopause Society, secretary ICOG, President MOGS in 21-22, Joint Secretary FOGSI 2017, and Quiz Committee Chair FOGSI 2009-2011. Welcome, ma'am, for the session. Our next chairperson is Dr. Chaitanya Chembekar, sir. I request Meenu madam to introduce him.
Yes, Chaitanya Shembekar, again, a very, very dynamic personality from Nagpur. He has been the past president of Nagpur OBGYN Society, chairman of Infertility Committee of MOGS. He has also been the librarian of Maharashtra ISAR, member of Infertility Committee of FOGSI. He has received Kamini Rao Yuva FOGSI Oration Award. I think forever you're going to be Yuva only, because for so many years I've seen you and you have always looked nice, bright and young. He has given many orations and talks, and faculty at various national and international levels, published many articles, and he's contributed many chapters and guide and mentor of MUHS and ICOG post PG fellowship at Omega Hospital, and he has also been involved with the clinical trials, Pearl, ECG, RI, ICMR trial, and he's a member of PCP NDT Nagpur. So thank you very much to be here to chair the session.
Thank you, madam. Thank you so much.
Thank you. Yes. So the chairpersons can introduce the speakers. Yeah.
Good evening to all. Good evening. Can you hear me?
Yes,
Yes,
we can.
okay. We have our first speaker, Dr. Belinda George, She is a endocrinologist, DM endocrinology, completed MD, MBBS, and DM from St. John's. Current position is Professor and Department of Endocrinology, St. John's Medical College Hospital, Bangalore, and Associate Medical Superintendent, St. John's. She was General Secretary, Karnataka Endocrine Society. Areas of interest are adrenals, gonads, pancreas. Recently published work on 46XY disorders of sexual development due to 5-alpha deficiency in a journal of pediatric urology, and current research activities comparing beta cell function among metabolically healthy, unhealthy, obese individuals. And Dr. Belinda will be speaking on the insulin resistance and its management. Over to you.
Thank you, sir. Can I start sharing my slides?
Yes, please. Yes. Just go on the green button, share screen. Perfect.
Are my slides visible? Okay, great.
Yes.
All right. At the outset, let me thank the ICOG and FOGSI. So today my talk will be on insulin resistance and its management. So there's a brief outline. We will look at what is the definition of insulin resistance, how to assess whether a patient or a subject that you're seeing has insulin resistance or not, what are the clinical features that can give us some clues to underlying presence of insulin resistance, what are the intervention strategies, and coming to today's specific discussion with in your field, we will look at a few aspects of insulin resistance and fertility. So let's start off with what exactly constitutes insulin resistance. So insulin resistance is basically defined as an impaired biological response of target tissues to insulin stimulation, which means if there is a target tissue, let's say the muscle in response to insulin is supposed to take up glucose from the blood or the circulation. So insulin will push glucose from circulation into the muscle. Now, if the muscle is not able to take up glucose in the presence of insulin, then we say that there is some amount of insulin resistance. So that is what it means in simple terms. And technically, any tissue that has insulin receptor can become insulin resistant, because then whatever action is supposed to happen there can actually not happen when there is whatever blocked the action of insulin. But metabolically, the most important organs which are involved in insulin resistance is actually the liver, the skeletal muscle, and the adipose tissue. So we will just look at that very, very briefly. So if you look at this picture, you can see the first bit is showing the liver and the hepatic insulin resistance. So what insulin is supposed to do in the liver is that once you have taken some food and the pancreas releases insulin, the insulin actually reaches the liver first before entering the systemic circulation via the portal circulation. And in the liver, more than 50% of insulin is actually extracted by the liver. And this insulin in the liver, what it does is it will suppress the liver from putting out any further glucose into circulation. So it suppresses hepatic glucose output. That is the main job of the insulin when it reaches the liver. So if there is insulin resistance at the level of liver, the insulin is not capable of suppressing glucose output, which means even after you have eaten, the liver will continue to put out glucose. So you have taken in food that is also increasing in the postprandial phase, but in spite of that, the liver is also continuing to throw glucose out into the circulation, whereby it increases your glucose concentration. The second most important organ is the muscle, where, like I just mentioned earlier, the muscle is supposed to take up the glucose. The muscle and the adipose tissue are the two organs which actually are involved in uptake of large amounts of glucose, predominantly the muscle. So if you have not, if the muscle is having insulin resistance, then glucose disposal becomes a problem and the glucose remains in circulation. Similarly, if you look at adipose tissue, you will see that there is impaired suppression of lipolysis because insulin is a hormone which actually blocks lipolysis. So because of impaired suppression of lipolysis, there will be a lot of free fatty acids released into the circulation, which again adds to the level of triglycerides eventually. So end result of insulin resistance, the main metabolic derangement you will end up getting over a period of time is that your glucose concentration in blood will begin to rise and the patient ends up having hyperglycemia or diabetes mellitus. But prior to developing diabetes mellitus, there is many years of persistent insulin resistance, wherein the pancreas overcompensates by producing more and more insulin in order to make it efficient. So at a higher level of insulin, you will be maintaining glucose concentration, which is what we technically call insulin resistance. So how do we assess if a patient has insulin resistance or not? So if you look at the gold standard, it is what is called the euglycemic hyperinsulinemic clamp. Now the principle of that is very simple. You start the patient on insulin infusion and you keep on increasing the insulin infusion to such a rate where the liver completely stops the endogenous glucose production and whatever glucose is present in the circulation is being taken up by the muscle. So if you want to maintain glucose in a particular range, that is what is called the euglycemic range, we are clamping the glucose at a particular range. And if you want to maintain the glucose in that range, you will have to start giving exogenous glucose infusion. So the amount of glucose you're infusing from outside is actually your EGP, which the insulin has suppressed, and you can calculate how much insulin you require to suppress EGP and facilitate uptake of glucose by the muscle. So this will give you an idea of the amount of insulin that is required for its biological action in that patient at that given point of time. But like you can see, this is looks like a very complicated and very difficult test to do. It's not easy for us to do euglycemic clamps in patients just like that, like how you would test your fasting blood glucose or postprandial blood glucose. So essentially, this complex method of assessing somebody's insulin resistance is very much limited to research settings and only done in certain institutes where these facilities are available. So it's not something that we can do. It's extremely cumbersome to do. So we have to rely on some other measure. So this is an easier thing. This is called the modified IV-GTT. Instead of giving oral glucose tolerance, we give IV glucose, and then we start looking at how the glucose and insulin behaves over the next couple of hours. Again, if you look at the graph, that graph actually shows you the number of points of glucose and insulin estimates which are required for us to calculate the insulin resistance, and it is actually more than 20 samples. So again, this becomes a very difficult test to do. It's not very easy for us to do it in simple clinical practice. Maybe for research purposes, you can subject the patient to such a test. So this is what we essentially use. This is what is used in large-scale research studies, where community-level or population-level research studies, where you want to do this in large number of patients. We can't go around doing clamp study in large number of patients. So that can only be done in very small studies, where you're looking at trying to identify a pathogenesis or a mechanistic, trying to describe a mechanistic issue. Whereas in large population-based studies, we will require indices. So these are very many indices which are available in literature, which has been validated against the gold standard, which is a clamp test. And largely the three agents that are usually studied are insulin, glucose, and triglyceride. And based on this, we have multiple indices which we can calculate. And this, I'm sure all of you are fairly familiar with. But let's think that, when a patient actually comes to you, is it really necessary for us to do all of these things to assess if the patient has insulin resistance? Or is there any simple clinical clue that will tell us that the patient probably has insulin resistance? So this is a classic sign called acanthosis nigricans, which I'm sure all of you are familiar with and all of you are seeing plentiful in clinical practice, and to examine for this, you don't even have to ask the patient to do anything extra. They don't have to take off their shirt or their blouse or take off their shoes, or you don't even have to make the patient lie down in bed. Simple patient sitting across from you, sitting across the table from you, it's very easy for you to look at the back of the neck and look for presence of acanthosis nigricans. Now, even though the neck is a classical site, you of course have in many different places. This is a picture which is showing acanthosis nigricans in the knuckles. Sometimes if it's severe, you can even have it on the face and the forehead, sometimes on the back of the elbows, cubital fossa, axilla. So this is again a very simple clinical examination tip which will tell us clearly that this patient has evidence of insulin resistance. This is another clue to presence of insulin resistance. So these are what are called skin tags. So again, skin tags are usually present either in the nape of the neck or in the axilla. And if you examine, you will see little pedunculated, just extensions of skin, which sort of hang like a bag. Usually they are colored very similar to the skin. Rarely they can be hyperpigmented, and they usually coexist along with acanthosis nigricans. So again, this is a very clear-cut clinical sign of insulin resistance, which you and I shouldn't miss when we are seeing patients. Now, this is a picture which I just wanted to show because this is a picture from AIIMS, wherein we are actually celebrating. This is the first patient, the patient getting the first COVID vaccine after COVID vaccine was introduced in India. So, of course, we were dealing with one pandemic, COVID, at that time. But if you look closely at this picture, you can see evidence of another pandemic, which is obesity. So here, if you look at the number of patients, at least 50% of patients has clear evidence of abdominal obesity. So central adiposity is another feature of insulin resistance. Again, we have an objective way of assessing it, which is using the waist circumference. But frankly, when a patient is sitting across you in your OPD, you don't even have to pull out your tape, because majority of the time, because we don't even look at what is obvious. Of course, ideally, we should measure the waist circumference and ensure that it's calculated and seen whether it's high. But most of the time, you don't even need to do it, because it will obviously be, there will be presence of central adiposity. So if you look at the waist circumference, for us Indians, it is 80 centimeters in women. That is predominantly the gender that you all will be dealing with. Another marker is, of course, BMI, but it is less sensitive in waist circumference because for insulin resistance, because as obesity increases, insulin resistance also increases. But central adiposity is actually a very good marker of insulin resistance. So these are clinical clues that we should not miss. We really don't have to do insulin levels in everyone. In fact, in clinical practice, I never order insulin levels. We do it only for research purposes when we want to publish a paper. But otherwise, we look for clinical evidence of insulin resistance, and then we intervene if necessary. So if you are seeing these patients and if you have noticed that there is evidence of insulin resistance, should you intervene at all? Of course, the answer is yes. But what are the things that you should do? First and foremost, when you see a patient who's come to you, let's say with menstrual irregularities or abnormalities, or even for subfertility, and you have seen that the patient has evidence of insulin resistance, the first thing that you should do is to ensure that there is no underlying or associated or coexisting metabolic dysfunction in this patient. So what are all the things that we should do to look for metabolic dysfunction? First of all, check blood pressure for all patients, because hypertension is a very closely associated with insulin resistance. Second, of course, look for hyperglycemia or diabetes. If the patient is already having diabetes and is on medication, then you can just do a fasting, a postprandial, and an HbA1c to assess the glycemic status. If the patient does not have diabetes or is not diagnosed with diabetes, then for the screening test, you could use FBS and HbA1c. It's a very practical, easy screening test to use. Ideal screening test is actually OGTT, but in clinical practice, we use FBS and A1C, which performs just as well as OGTT, and we use OGTT only when we are in confusion with regards to the diagnosis or when we're not clear. The other aspect that we should evaluate the patient for is dyslipidemia. So get a lipid profile which includes LDL cholesterol and triglyceride at least. So these are the two fractions that are extremely important for us with regards to intervention. And of course, we are all aware of the fact that I just mentioned insulin resistance. One of the major organs it involves is the liver. So liver function tests and the presence of metabolic associated steatotic liver disease is coming up in a big way, and non-alcoholic liver disease as a cause for CLD is also increasing. So metabolic associated liver disease, it's important for us to screen them early. And now we do have medications which can actually be helpful in this situation. So if you've evaluated for this and you found that there is no metabolic dysfunction, then it's a good idea to retest the patient at least, once a year is a good gap to give. In fact, if you look at ADA recommends if the patient is absolutely normal, the next evaluation can be 3 years later. So, but remember that just once single time evaluation is inadequate. You have to evaluate if the patient is having any borderline issues. Maybe we can evaluate in 3 to 6 months, and if it's absolutely normal, maybe we can do the next evaluation at 1 to 3 years. But more frequent evaluation than that is really not necessary. So what can we do? Let's say the metabolic derangements we look for because we need to intervene for them separately. If you find anything, you can refer the patient to a physician to do whatever is required. Let's say the metabolic tests have all come back as normal, but you know that the patient has insulin resistance. So what are the changes that you can advise the patient to do? So we all talk about lifestyle changes. The 3 main pillars of lifestyle changes is diet, physical activity, and sleep. So I think whenever you get an opportunity to meet a patient who has probable insulin resistance, it's important for us to underline and give them underline these issues and give them appropriate advice with regards to diet, physical activity, and sleep. With regards to diet, if you look at it broadly, any sort of diet is okay. All diets work as long as it's followed. All diets fail to work the day you stop following it. So that's the simple dictum with regards to dietary intervention. Whether you want to do calorie restriction, whether you want to do intermittent fasting, whether you want to do any other kind of fat diet where you're cutting out certain macronutrient, whatever it is, all of them will work, remember, as long as you do it. So you can't diet for 6 months and then go back to how you were earlier. That is not going to work. So I think the simplest diet would be what I generally tell patients or tell friends, actually, which is called the ELF diet, which just stands for eat less food, because most of us are actually eating more than what we should be consuming, which is the reason for our obesity. Physical activity, of course, is extremely important. So encourage patients, whatever suits them. Some people may just like walking. Walking is a safe activity which we can advise everybody across all age groups to do, because you're not going to introduce any sort of if you have not assessed for cardiac ailments, underlying cardiac ailments, still okay to advise someone to do physical activity like walking. But of course, when you're seeing young patients in whom weight loss is a target, a little bit more intense physical activity is probably appropriate. Another overlooked feature is sleep. In today's world, sleep is, most of our patients and most of us are also terribly sleep deprived. So this is something that we should not forget to look at and address if necessary. With regards to medications, of course, if you have insulin resistance, it makes sense to use insulin sensitizers. But the fact is that no drug is FDA approved or having approved by any agency to treat insulin resistance. We always target the associated metabolic derangement, or if there is another comorbidity associated with insulin resistance, and then we target that, and the drugs are all directed at that. But all of these drugs have shown in clinical studies to reduce insulin resistance. Largely, they work, different ways. Of course, pioglitazone and metformin are true insulin sensitizers, but most of the others work by reducing weight. Even bariatric surgery in patients with morbid obesity can actually improve insulin resistance simply by weight loss. And inositol is a drug that you all use very frequently, which also has insulin resistance. So just one word on insulin resistance in lean women, because that is seen particularly by all women with lean PCOS. But majority, 80% of women with PCOS and insulin resistance will be obese. But there is a small subset who are lean and will not have high BMI or high waist circumference, but they are likely to have coexisting insulin resistance. And this insulin resistance may be driving their PCOS or vice versa. So in these patients, acanthosis may be present, but other features that we just discussed may not be that prominent. And acne hirsutism are similar to patients with obese PCOS, because the PCOS is their underlying issue, and they may not have much metabolic derangements because the obesity and fat deposition is not that much of an issue. One thing that we should remember to rule out in this scenario is late onset congenital adrenal hyperplasia, because they may present they may cause secondary PCO and have hyperandrogenism and may present very much similar to this. So I just wanted to mention, this is probably the only place where your clinical clues may not be convincing enough for you to identify insulin resistance, and you might have to do an additional test to ensure that to check whether the patient has insulin resistance or not. Coming to the last aspect of my talk, which is looking at fertility and insulin resistance. Recently, there's been a whole lot of literature about how fertility is affected by insulin resistance. And female infertility in today's era is basically coined as a clash of two pandemics, because now, because of underlying insulin resistance and a whole host of other issues like chronic inflammation and oxidative stress that comes with it, there is something that is called dysmetabolic infertility. So the dysmetabolism itself is contributing to infertility, and that is being increasingly seen across our patient population today. So if you look at the women seeking pregnancy also, you will see that they are heavier and older than in the past. And you will see that most of these patients, beyond taking a longer time to conceive, even with regards to IVF success, it's lesser than how it was, in the pre-obesity era, if you could say so. And we know that lifestyle interventions are known to have a benefit with regards to insulin resistance in weight, but we will look at whether clearly there's not much evidence looking at evidence looking at lifestyle changes or even pharmacotherapy prior to fertility therapy. So this is a Cochrane review which has looked at insulin sensitizing drugs in women with subfertility. And this is specifically with regards to metformin versus placebo studies. And here they found that metformin can actually improve live births compared with placebo. And with regards to, there's a low quality evidence, and with regards to other effects like higher rates of clinical pregnancy and ovulation, and all of them had some amount of moderate quality evidence, and there was no increased miscarriages. So we know that metformin may not be a very, very potent therapeutic agent, but definitely there's no harm with metformin, and there may be some benefit with metformin. So which is why metformin is used left, right, and center across all aspects of infertility, subfertility, even in PCOS women. With regards to other insulin sensitizers like inositol, dosiglitazone, pioglitazone, the number of studies, of course, were very small, but also there were not enough studies which reported primary outcomes. So there's not enough evidence currently to support the use of these. So my last study would be this, which is a recent study published last year, which looked at effect of lifestyle or metformin intervention before IVF ICSI therapy in women, in infertile women who had obesity and insulin resistance. So here what they have done is they have divided into four groups. One would have only lifestyle intervention, one would have metformin intervention, then there's lifestyle plus metformin, and the last group did not have any intervention. And results-wise, they found that the metformin, wherever metformin was used, there was a higher response with regards to live birth rates. Though weight loss was present, insulin resistance came down, all that happened even with lifestyle intervention. But maybe because the sample size was very small, maybe you need to study a larger sample size to really look at the effect of lifestyle intervention with regards to live birth rates. So in conclusion, insulin resistance seems to have a negative impact on multiple aspects of reproductive health and fertility. And as practicing clinicians, every woman that we see in our clinic is an opportunity for us to identify and intervene, because truly we have to mitigate this increasing burden, because we are seeing obesity, echinodoses, insulin nigricans, echinodoses, nigricans, and insulin resistance in very, very young girls these days, which is fairly disturbing. And so I'm sure in the next decade or so, this dysmetabolic fertility is going to be a primary concern for you all. So instead of, we don't always have to order a lot of fancy tests to identify it, because most of the time it's staring at us on our faces. So just look out for clinical clues and identify insulin resistance whenever it's present. And wherever feasible, we have to keep repeatedly advising them with regards to lifestyle changes, because it's not very easy to adapt a new lifestyle and stick to it. We will all adapt it when the motivation is high, and then we'll give up on it within 1 or 2 months. So repeated enforcing becomes very, very important. So lastly, pharmacotherapy to address insulin resistance in the absence of metabolic derangement. So whenever there is metabolic derangement, it's very clear we can definitely have medications to intervene. But whenever there is no metabolic derangement, but there is only mild subfertility, there we do not have enough evidence yet. Thank you. So with that, I'll stop.
Yes, we will have the comments from the chairperson. And but we will not take questions. We will take only. Can you answer on the chat box all the questions, please? But we will take the comments.
I
on
think
the...
we will take the questions. I think.
Sir, in the chat box, they can answer. The faculty can answer in the chat box, but you can give your comments, sir.
I think
Yes.
it was well covered. It is actually insulin resistance, even though we see a lot of PCOS patients. It is really challenging, and that was very simplified and well presented by Dr. Belinda. I think Sarita Madam and Chaitanya.
Yes.
I think
I think they're not there, sir. I think.
yes.
Okay. Okay. So thank you very much, Dr. Belinda George. There are few questions in the chat box. Please, can you be kind enough to answer them so everybody can also read the question as well as the answers that you have. Thank you very much for enlightening talk.
So now we move on to the next talk. That is by none other than Dr. S. Krishnakumar sir. So I would request FOGSI sir to please introduce him officially.
I think it is my proud privilege to introduce Krishnamar sir. Sir is the chief consultant of JK Women's Hospital and Fortis Hospital and Kalyan, and past president of Indian Association of Gynec Endoscopy, and center recognized for ICOG fellowship, 6 months ART and endoscopy surgery. Course in charge of IAG, cadaver course, and AGL Centers of Educational Excellence in minimum invasive gynecology. Recent recipient of IMA award, Eminent Medical Men. And also, sir is very active in ESAR. He was a secretary. I think sir will be talking today about hysteroscopy in all before IVF. Is it essential? Over
Can I
to
share
you,
the
sir.
screen? Can I share the screen?
Yes, sir, please.
Yes, sir.
Yes, sir.
Yeah. Thank you, FOGSI, for the nice introduction, and thanks to the ICOG for inviting me in this online course on infertility. Of course, the topic is given to me is a very old topic where at the very outset, everybody will say hysteroscopy is not needed before IVF. But then that the very fact that you have thought that it should be again discussed means there are recent interest on that, and I will try my best to see what is the role of hysteroscopy, whether in all or at least in majority. Now, we all know that the uterine cavity and endometrium is the most fundamental for the implantation of the embryo. But, and you also will agree that endoscopic evaluation of the uterine environment in the infertile couple is still understudied. Maybe because of the progress in the imaging or sonography. And that has really cut short the need for hysteroscopy in so many. And the debate seems to be never ending whether hysteroscopy prior to IVF, does it really improve the reproductive outcome or ART results? The debate continues. And we all believe that in optimizing embryo culture condition, the first 5 to 6 days in the laboratory is very, very essential and very strict. But definitely we have to believe that the anatomic factors affecting the next 9 months is also equally important and cannot be neglected. I'm sure the background why hysteroscopy is not considered, if I just have to go to very short, of these two studies, the INSIGHT and the Trophy studies. When they came back in about maybe 2 decades back, maybe 15 years back, both of them suggested that before the first IVF, the pregnancy rate seems to be almost the same. The live birth rates remains the same. And the Trophy studies in patients who had undergone implantation failure or fertilization failure even failed to conclude the hysteroscopy being performed prior to the second IVF did not improve the results. Now, what could be the reason? Well, on one ground, we know that advanced imaging, the evolution in the sonography which has happened such a high resolution as 3-dimensional and 4-dimensional, and today we have contrast ultrasound, ICOG, and so many things. I wouldn't go into a detail of those things. Each one of us seen the excellent images being produced and has definitely reduced the screening hysteroscopy role in modern times. But unsuspected abnormalities on hysteroscopy, if you look at the literature, it varies. High prevalence ranges have been reported from 10 to 11% by Pundir et al. And almost 40 to 60% by this in these various articles published by El Nassar, El Sarti, and Bastu et al. Published as recently as 2018. 40 to 60% unsuspected abnormalities have been detected. Maybe these centers did not have advanced imaging. So could be one of the reasons where such a high abnormalities have been picked up only on hysteroscopy. Now, if you look at the hysteroscopy, these microscopic features, basically today we also now are more and more talking about endometrial flora, the endometritis, and it has been proven that almost 30% of patients with implantation failure, the endometritis could be one of the main reasons for the same. So abortions and recurrent pregnancy loss, it has been reported between 9 and 67% by the study by Song et al. Well, if you look at the lesions which can be picked up by hysteroscopy, micropolyps, like you see, this focal hyperemia, stromal edema, which is so classically seen in tuberculosis or non-tuberculous chronic endometritis, the strawberry appearance, which is very, very again classical of endometriosis, or somewhere Staph aureus infection we have seen, and endometrial hemorrhagic spots. Now, these things definitely cannot be picked up by imaging. That's what hysteroscopy makes inroads into this part of the uterine evaluation, where you can pick up these things and you can take a nice biopsy and then confirm and also have culture on them, and then accordingly go ahead and treat that particular condition before the next transfer. So these are some of the things which can be missed by imaging. We all are aware about it. Well, what is the sensitivity of the ultrasound? Definitely, if I have to tell you that imaging equipment and modality is something there. Now we have seen tremendous growth of the models which are coming up. But many of us or many of the sonologists are still dealing with the machines which are not really updated and really cannot give you all those readings and results which many experts do show it. And of course, it depends on the competence of the operator. And another thing which I don't have to emphasize is the patient characteristic, the pathology which is screened for, the global changes like hyperplasia and endometritis, which I just showed you, imaging cannot. Whereas space-occupying lesions like polyps, fibroids, septum can all be detected by these 3D and 4D ultrasound. But definitely the competence of the operator is equally important. And despite this recent Cochrane review in 2019 said that in women undergoing IVF, there is a low quality evidence, including of all the studies, suggest performing a screening hysteroscopy before IVF may increase the birth and clinical pregnancy. The evidence is still low, but there is some evidence as far as this Cochrane evidence in 2019. But ESHRE in 2023, in the recommendations, the good practice recommendations of hysteroscopy before IVF, it is not recommended as per the ESHRE recommendations. So the debate seems to be continuing in spite of good evidence on role of hysteroscopy. Well, I found this article published in 2020, Fertility, Sterility, Time to Pregnancy is important for patients and underestimated by doctors. In even an article published in the US journal where they say that how many of the couples who do not become pregnant after one IVF cycle abandon their IVF attempt at all. Maybe in the subsequent cycle, they would have had a good chance. But because of the stress involved, they stop the treatment. Whereas in a country like India, I think it is much more relevant because of these following reasons. In Indian scenario, our patients are paying from their own pocket for their IVF cycle. So for one cycle, if they have to shell out a couple of lakhs by taking loan and things, and the moment you tell that your cycle failed and I didn't see the uterine cavity for the next cycle, I'll make sure I see the uterine cavity and then I'll go and transfer. The question is, doctor, why didn't you see what you're putting in before, whether it's all healthy? So you have no other rights. And India, this D and C, the full form of which I hold as dangerous and contraindicated in the reproductive age group, is still the most common intrauterine surgery. We all know that for everything, anything, people do perform D and C still. A lot of intrauterine adhesions are known because of that. And India has more prevalence of chronic endometritis and FOGS. So all the more hysteroscopy is needed for our patients. So we have to adapt to our conditions and not just depend upon these guidelines. And hence, I had this wonderful conference just a couple of weeks ago, where hysteroscopy and sonography compounding their results for improvement in infertility. But are we having the same type of imaging, the same type of great operator in sonology everywhere? The answer, I'm afraid, is definitely no. We all demand with our investigation, locate this, locate that. Are the sonologists up to the task? We are progressing in infertility, but are the sonologists progressing in infertility imaging? Again, are the patients sensitive? Many of the time I tell them, come to my center to have this evaluated. They just say that I've got a center very close to my house, and they do it and come back, and we cannot really explain to them. And you will all agree, we have adjuvants everywhere in infertility, IVF, adjuvants for ovarian response, adjuvants for sperm, adjuvants for endometrium and implantation. The list here for the endometrium and implantation is endless, you can see. And we still see in many of the centers, all these adjuvants are just added, and added. Well, we have to be truthful, to be honest here. Excepting endometrial scratching, most of them have red color. I mean, they are supposed to be harmful. Only endometrial scratching, which could be done by hysteroscopy, is still having an amber or an orange color. Instead of being helpful, it has been shown to be hopeless by this study published in December 2019 by Farquhar et al. So we need to be really honest in using those adjuvants. And hysteroscopy as an adjuvant, because of the endometrial scratching, it might help receptivity because of the expression of increasing the expression of gene encoding factors like glycodelin A. There are enough papers to do that. So are we missing out on something which we have to see? And today we all have moved from operation theater hysteroscopy to ambulatory hysteroscopy. Means hysteroscopy without anesthesia, where pharmacological drugs are not used, where that particular harm or the fear of invasiveness, where you don't have to dilate. The moment you dilate and do, you're going to cause more damage, perforation. So all those things are now avoided by this vaginoscopic technique, and ambulatory office hysteroscopy is the order of the day. The world has progressed, and more than 2 decades, there are enough papers to study that tell you that the satisfaction on the OR and the ambulatory hysteroscopy, both for the patient and the clinicians, has been amazing. So our acceptance is still less. We all still do not believe in doing ambulatory. So maybe hysteroscopy pre-IVF will also tell you about the canal progress, whether there are any polyps, any obstruction, we all have found many a time difficulty in embryo transfer, and we delay or we then freeze the embryos and come back to the next cycle, like this in case you can see in this patient who had a very angulated cervical canal and the internal os, and you can see them, identify them, and correct them at the same setting, even in ambulatory setting. So the course and morphology of the cervical canal is at your hand before taking the patient for an embryo transfer. So this is the beauty of hysteroscopy: see and treat at the same time. You don't waste time there, you can do it. And the fallacies of the INSIGHT and Trophy trial was not discussed until this article in 2019 by Parry and Isaacson, where they said that in the Trophy studies, about 45% of the patient had already undergone hysteroscopy before they had been enrolled into this. And what was the success rate of the INSIGHT trial? Hardly 24 and 29%. And that is unacceptable, because they had excluded those patients. Almost 10% results could have been improved if maybe you had done it and you had detected the chronic endometritis and treated. So this is a fallacy of this INSIGHT and Trophy trial. And still, many of the centers still talk about this and say that this has proven that hysteroscopy is not required. And this very beautiful article published in December 23, recent article published in the JMIG by the AGL, where a lot of the analysts are all people who do ambulatory hysteroscopy, and it's worth reading. And what they concluded in this trial, they said, in this they found out that the clinical pregnancy rate seems to be favoring hysteroscopy. As per so many studies, you can very well see that definitely the control had a much lesser pregnancy rate clinically. But unfortunately, when they took all the trial, the live birth rate didn't seem to be very high in the patients who did for hysteroscopy, favor hysteroscopy. But what they again concluded was amongst those trials which included only RCTs, again, the odds were favoring hysteroscopy to improve the clinical pregnancy rate. So definitely there is a lot of light at the end of the tunnel. So their recommendation was this supports an improvement on an IVF effectiveness. I wouldn't read the whole conclusion which they said, but considering these advantages, a routine diagnostic hysteroscopy may be considered as a new standard before starting an IVF ET cycle. But again, I would emphasize ambulatory hysteroscopy. So that is something which we all are missing, and we have to take it up, and we have to learn the way of doing ambulatory hysteroscopy. And hence, to tell whether hysteroscopy for all, the decision to proceed definitely must be predictated on a patient-centered discussion. We have to counsel them, determine, of course, it has to be decided with the patient. You have to tell those things what you're trying to do, a presentation, an assessment, and of course the resources available to the managing team. But definitely ambulatory hysteroscopy should be there, and it's really a time to rekindle the expertise for the benefit of our patients. They deserve nothing less. Here, though you can see in the operation theater, we do it without anesthesia, a mini resectoscope being used in a patient. You can see the patient. We are talking to the patient every time, and she is moving her head. She is talking to us. Means you have to see to believe that even resectoscopic surgery can be done in an ambulatory setting. And today we have the availability of beautiful HTRS, the mini intrauterine morcellator or retrieval system, which is much better, avoiding energy and so many other things now. So definitely we have to think whether should we do hysteroscopy for every patient before IVF. Thank you for a patient hearing.
Superb, awesome talk, sir. I think you have convinced everyone to put that little small office cystoscope of yours and check the cavity before taking the patient for
It's so
AIU.
simple. It's just 3 to 5
We
minutes.
have comments from the chairpersons, and also, sir, a lot of comments, compliments for you in the chat box. And can you also please answer the questions in the chat box?
Yeah, I'm not
FOGSI,
able
sir,
to
are
see.
you there?
Yeah, I think FOGSI is there. FOGSI, on mute. Yeah.
Yes.
Yeah, in ambulatory hysteroscopy, can syncytial be done? Definitely, yes. You all have to know that endometrium does not have nerves. Every month it falls and it grows. So early adhesions, definitely, but late adhesions, the moment myometrium is too much plastered, it's going to be difficult because myometrium is going to be painful. But definitely, early and or moderate adhesions can definitely be treated in ambulatory settings.
Especially, sir, the smaller scopes, we can easily do that, no?
Yeah,
Ambulatory
4
anesthesia.
millimeter sheath with 1.9, or of course even with 5 millimeter sheath and 2.9, I still find that most of them still don't use. Everybody uses that 4 millimeter telescope with that 7 millimeter or a 9 millimeter sheath and dilating and creating all sort of complication and nonsense, and still they call it as invasive. It is definitely not at all invasive if you can do with those mini hysteroscopes and do it within 3 to 5 minutes.
Only thing you need to have proper instruments. Instrument.
Of course, for any surgery you need good instruments, and one cannot compromise. Hysteroscopic instrumentation is much lesser costlier than laparoscopic, equipments and instrumentations.
So, thank you very much, sir. Thank you for the nice lecture and nice comments. Dr. Sandhya?
Thank you so much.
Thank you.
Thank you,
Yes,
Dr. Madhuri Patil, for involving me, and thank you to FOGSI and, of course, Meenu for conducting this course wonderfully. Thank you.
It was a nice lecture. I mean, it was different because everybody today says that hysteroscopy is not required, but you did, and you did convince that hysteroscopy is required.
Yes, why not do? Because when I tell on the second attempt that I'm going to do hysteroscopy and then put the remaining embryos, the question is why you didn't see initially something which you're putting inside. Then one Maharashtrian commented that दूध उकळायच्या आधी तुम्ही भांडी धुतलंच नाही असंच केलं. Then how to answer such patients? Our patients are peculiar, and we have to really, time to pregnancy for them is very important, and so we need to look into this ambulatory hysteroscopy in a big way.
Yes. Totally agree.
Thank you.
Thank you, sir. It was a wonderful session as always. It's always pleasure listening to you. I would now we move on to the next talk, and that is by Dr. Durusha Madam. And I request FOGSI sir again to please introduce Durusha ma'am.
I think it is again a proud privilege to introduce Durusha Madam. Madam is the director of the Gynec World Center for Women's Health and Fertility, founder president of PCOS Society. I think we had that annual conference last week, and Madam is the I think involved in the PCOS consensus forming with the PCOS Society, playing a very big role internationally. And Madam is a consultant of gynecologist and fertility expert in the Breach Candy Hospital and Jeslock Hospital. Areas of interest are reproductive medicine, including infertility, assisted reproduction, PCOS, premature ovarian insufficiency, and first and only Indian to receive FOGSI, a Distinguished Merit Award for services towards women health, and received a Black Swan Award for the woman empowerment, and received the Mahatma Award 2021 for social responsibilities and gender equality. Over to you, Madam. Madam, are you there?
Yes,
I'm here.
I'm just adjusting my screen. Give me a minute, please.
Yes, sure. And thank you, Madhuri Patil ma'am, once again to get faculty like Durusha ma'am. I mean, thank you so much. You got all the best faculty suitable for this course. We are so looking forward to listen to you, Duru.
Can you see my screen?
Yes, not only the okay.
Not we cannot see it.
Oh.
Yeah, we can see.
Now
Just
we
put
can.
it on the show. Slideshow.
I don't know, something's wrong with my thing today. I'm not able to put it into full screen mode. I'm sorry about that. I was trying before, but it was giving me trouble. So I'll work like this. Is that okay?
Yes, Madam.
Okay, fine. Thank you so much for having invited me, and I'm happy to be on this certificate course, and which I suppose has now become what do you call it, a weekend course. This is what I was told by Madhuri. Am I right? Yes. Okay, so coming to the subject, since we have only 15 minutes to speak, first of all, I'd like to speak on the subject of, as I have mentioned, luteal phase dysfunction and endometrial receptivity. So we have a situation wherein we are talking about strategies to improve ART or assisted reproductive technology outcomes. And we know that the best outcomes occur with endometrial embryonic synchronicity, where the both of them are on the same page, sort of, optimal timing of the embryo transfer, best endometrial preparation, and an optimal luteal support. So since we are talking about luteal dysfunction, I will go straight into the luteal phase support. Now we know that the corpus luteum is a temporary endocrine gland which has a major source of steroid hormones. And the maximum amount of hormone it produces is progesterone, about 40 milligram a day. Besides that, it also secretes estradiol and androgens. And all this progesterone takes care of the menstrual cyclicity, it takes care of follicular cell luteinization and the rescue of the corpus luteum and development, and also the endometrial receptivity takes care of the endometrial receptivity, which takes care of successful implantation, essential for maintenance of early pregnancy. The corpus luteum, which is present in a fertile cycle, we know that it sort of HCG appears on day 8 after ovulation and rescues the corpus luteum. Normally, the corpus luteum remains alive for approximately 10 to 11 days. And this is something which it stays naturally. And after that, it sort of collapses. And when it collapses, the progesterone hormone stops getting released from there. But if a woman is pregnant, the HCG starts appearing on day 8 after ovulation through the embryo, and it rescues the corpus luteum. This is called the corpus luteum rescue. This HCG stimulates the LH receptors on the corpus luteum and increases the progesterone levels, which expands the vascular network of the granulosa and theca cells. So there's a lot of angiogenic factors released, which are mainly the vasoendothelial growth factor and the relaxin. So the VEGF, which we read every time, and relaxin, which help the corpus luteum to respond to the HCG. If there is no HCG, the corpus luteum cannot be rescued. And therefore, unless there is HCG in the circulation, the corpus luteum will degenerate after a certain amount of time. It also helps to prevent apoptosis of the corpus luteum by decreasing the pro-apoptic protein banks in the corpus luteum. So normally there is something which is pro-apoptic, means it automatically sort of gets rid of the corpus luteum. But when this VEGF and relaxin is present, it prevents this apoptosis. And this is something we need to understand, that if we give HCG to a patient, either exogenously or it's created endogenously by a pregnancy, only then does a corpus luteum get rescued. Now, the functions of the progesterone are, we know that it helps in the molecular signaling between the endometrium and the blastocyst crosstalk. It's required for the blastocyst adhesion, and therefore, if there is not enough progesterone, the blastocyst will not adhere. There is also a remodeling of the epithelial and stromal tissue in the endometrium, which causes the decellularization. It helps to reduce the contractility of the uterus after the embryo transfer, and it helps in the feto-maternal crosstalk. So we know that the role of endogenous progesterone, in short, as I've mentioned to you all, that it helps to create that window of implantation, which is the area where endometrial receptivity is being measured. And therefore, in natural conception and in assisted reproduction, this varies. The window of implantation will vary depending on what kind of cycle has happened, has been taken, a sort of protocol has been used. So if you see that if one does the progesterone levels in the follicular phase, even before ovulation has occurred, and if the level is more than 1.5 nanogram per ml, it suggests that there is a premature LH surge or a premature luteinization which is occurring, and this causes endometrial asynchrony with the blastocyst, and therefore the pregnancies will not occur. So if we are going to do a progesterone level prior to giving the trigger, or prior to, say, we normally do it when the follicle size is around 14, and that is at 14 mm, and that is the time if you find that the progesterone levels are going up, LH levels are going up, it goes beyond 15, then we say that this is a case where there is premature luteinization or premature LH surge, and that is causing the problem, and therefore in that case we may not transfer the embryos in the same cycle. if the progesterone levels are less than 10 nanograms per milliliter in the luteal phase, then luteal phase progesterone is best measured around day 21 of the cycle, where you expect ovulation around day 14. And if you find that there is a less than 10 nanograms per ml, you know that this will suggest luteal phase insufficiency and give rise to infertility and recurrent pregnancy loss. The endogenous progesterone in fresh IVF cycles is known to be deficient because there is an extra amount of agonist and antagonist being used, and these inhibit the LH secretion. The reason we use the agonist and antagonist is because we want to prevent a premature LH surge. But when we prevent the premature LH surge at the same time, we are suppressing the pituitary gland with that agonist or antagonist, and that prevents the release of LH from the pituitary, and therefore there is not enough stimulation occurring to the corpus luteum to secrete any more progesterone. So this is how it works, and therefore when we use an antagonist or an agonist, we need to do a good luteal phase support through exogenous progesterone. Now, if you look at a luteal phase in a natural cycle, in a natural cycle, the single follicle, if there is only a single follicle, which usually it is, the estrogen level is around 200 picograms per milliliter. But when we are doing an ART cycle, there are multiple follicles, and each follicle is producing estrogen, and the estrogen level may go up from 1500 to 3000 picograms per milliliter, depending on the number of follicles which are dominant. And if you look at a natural cycle on day 7 after ovulation, where is the time where you measure the mid-luteal progesterone, which is necessary for successful implantation? It is 10 nanogram per ml. Whilst in ART cycles on day 5 or 7 after the ovum pickup, the level comes to 30 to 50 nanograms per milliliter. Reason being, there are many more follicles, many more corpus lutea, which are secreting progesterone, and therefore the level is higher. So if you look at this graph and you see that the red line or the red bar is the one which is a natural cycle, where you see after ovulation the progesterone levels are high in the luteal phase. The green line is the one which is a cycle with GnRH analog and HCG, wherein we have given a trigger, the HCG trigger, which also acts like LH and can stimulate the release of LH, progesterone from the corpus luteum, because corpus luteum carries LH receptors. And when you give HCG, it behaves like LH and it stimulates the receptors for progesterone on the corpus luteum and helps the release of progesterone. Then you have the blue line, which is cycle with GnRH antagonist plus agonist. So there you see in the luteal phase, the progesterone levels are very low. And therefore, if you're using both agonist and antagonist cycle, the progesterone levels being very low, you really need to support that luteal phase very effectively and very well. So luteal phase dysfunction, actually, what are the different consequences in ART which can occur? As we said, it causes poor endometrial receptivity. It has dysfunction of local uterine immune system, leading to increased risk of embryo rejection. There is increased uterine contractility, and there is restricted blood flow. This is because there is a dysfunction of the luteal phase, and therefore it will not give you good results if there is such dysfunction. So the causes, as you see, of luteal dysfunction will be either it's a deficient corpus luteum because you've used GnRH agonist or antagonist in the ovulation induction protocol. It may be because you have done an ovum pickup in a fresh cycle and there is a depletion of granulosa cells due to the ovum pickup. So there are less granulose cells in the follicle, and therefore there are less luteal cells in the corpus luteum, which will release less of progesterone. Third is if there is controlled ovarian hyperstimulation, where you have stimulated more of the follicles, and therefore there is a reduction in the LH, because when the estrogen will rise, it will also give rise to suppression of the LH. And lastly, it could be the ovulation trigger, which is used, which is a GnRH agonist trigger, which we use nowadays, and that itself will cause luteal insufficiency. On the other hand, you may have normal corpus luteum, but a defective endometrial response. And that defective endometrial response may be because you've given progesterone in the very high levels in the early luteal phase. And that is something you must remember, that after your putting in the embryos in the ART cycle, you have to be very sure that the progesterone levels are good before transferring the embryo. Then you may have endometrial progesterone resistance, which is usually seen in patients with PCOS and endometriosis. And then you have the abnormal endometrial response to the progesterone, which is circulating well in the system, but the endometrium is not responding. Now here, if you look at the progesterone deficiency in ART, there are 3 graphs here. The first graph is the one with a natural cycle, which is a conception cycle. As you see over here, the progesterone normally will go down by the 10th day or so, and then by the 12th day or 14th day, she'll get a period. But if the pregnancy occurs, which happens around day 8 of the post-ovulation, HCG starts getting released. And as HCG goes up, it is protecting, or it is rescuing the corpus luteum and allowing the corpus luteum to grow further up to 6 weeks of pregnancy. And there you find that the progesterone will go on rising in a conception cycle. Whilst if you see in the next cycle, where the cycle has been down-regulated, where you down-regulate, there's hardly any progesterone being secreted post-ovulation. And therefore, it definitely needs luteal support, and there's no conception if you are not going to give any progesterone. And again, if you have a down-regulated cycle, the first one was where there is no conception, and in the second one, where you give the support, and then you get a conception. So this is how you can understand that you definitely need progesterone support in such patients, and therefore you must be careful about how you give your progesterone. Now today there is no really good way we have of assessing luteal phase deficiency. The only thing we have today is to do the serum progesterone levels, which has given us an idea whether the progesterone level is good or not. By looking at the endometrium, we can manage it pre-ovulation, where we see not pre-ovulation, we can see the endometrium triple layer, etc., where you know that the follicles have grown well, there's enough estrogen, etc. But in the luteal phase, it's very difficult to know whether there is enough progesterone in circulation and whether it will give you good results. And therefore, coming to the management, how do you manage this? What we can do is that we have to have 2 types of luteal phase support. There is a meticulous control of LP in each ART cycle. Either we do it exogenously, where we give the progesterone supplementation from outside, either oral, vaginal, or injectable, or it can be an endogenous secretion of progesterone, which we cannot use in the frozen cycles because there's no corpus luteum there. And therefore, you have to give exogenous progesterone. Whilst if you're doing a fresh cycle, there is some amount of progesterone being released, especially either in a natural cycle or a modified natural cycle. There will be a corpus luteum and there will be secretion of progesterone. But this progesterone is something which we can, if there's a corpus luteum, we can stimulate further progesterone secretion either by giving HCG to the patient or by giving GnRH agonist only as a trigger. And that can probably help to release more progesterone. Now, this is a study which is a 10-year study, which was between 2009 to 2019, which were following up on the practice of luteal phase support through web-based surveys. And what they talked to the various clinics and found out, okay, what really is happening, when do you use the progesterone and how do you manage it? And what was told by the physicians was that most of the time, if you see in 2012, they were 80% of the physicians were giving progesterone on the day of the ovum pickup. Whilst on the day after ovum pickup, there were about 40-41% giving progesterone on the day after ovum pickup. And on the day of ET, there was even less, and a few days after the ET, also further less. But on the day of ovum pickup, on an average, you'll find that most of the physicians were giving the progesterone on the day of ovum pickup. And this is the pattern which most of the centers follow. And majority have said that, even the ASHRAE guidelines have said that we must start the luteal phase support between the evening of the ovum pickup day or till the day of three days post ovum pickup, especially if we have used HCG as a trigger, which will help to support in the first few days of the luteal phase. Whilst if it's a frozen cycle, you cannot do that. So this meta-analysis, which is the duration of supplementation, where you give a prolonged support or you do early cessation of support. Now this is something which constantly people ask, till when do you give the progesterone support? So the studies have shown that prolonged progesterone may be unnecessary after a fresh embryo transfer, whilst larger RCTs are required to standardize still the duration. We still don't know how much to give, but important to remember that the corpus luteum, even if it is rescued, it remains alive only till about 7 weeks of pregnancy. And by 7 weeks of pregnancy, the placenta starts developing, though the placenta is not completely well developed till 9 weeks of pregnancy and takes over the function of producing progesterone. And that is what we need to address, is that till 7 to 9 weeks, there's a takeover from the corpus luteum to the placenta, and therefore, in my own experience, I prefer to continue using the progesterone at least till then. Now again, the progesterone which you give will depend on whether it's a natural cycle, modified natural cycle, or an artificial cycle, where the frozen cycle is concerned. When the frozen cycle is concerned, this is what we do, and we must remember that there's no corpus luteum if you're doing the artificial cycle, and therefore those are the patients, because there is no release of VEGF and relaxin from the corpus luteum, those are the patients who will have a reduction in systemic vascular compliance, leading to increased hypertensive disorders of pregnancy. Serum progesterone, outcomes of serum progesterone in the luteal phase in frozen embryo transfer cycles. It is very difficult, but this systematic review has looked at 21 studies with 6,175 frozen transfer cycles. They included women between different age groups. They looked at autologous and donor cycles, and they looked at different formulations. And what they found is that if the progesterone level is less than 10 nanogram per ml, just prior to frozen embryo transfer, the pregnancy rates were lower and the miscarriage rates were higher. But if it was 10 nanogram per ml, it is associated with better treatment outcomes, probably due to different, and people use all kinds of progesterone, oral, vaginal, etc., etc. But what is important is 10 to 20 is good, but above 30 may be detrimental, because the endometrial receptors get saturated at a level of 3.14 nanogram per ml. So this is our own data, where we are looking at, doing the progesterone. This is not the one I want to show. I'm sorry. This is on the day of 1 day before the embryo transfer. Yeah, this is our experience. And here, if you see that if the progesterone is 10 to 20 on 1 day before the embryo transfer, then we get better pregnancy rates and live birth rates. Whilst if it is between 20 to 30, the pregnancy rate is fine, but the live birth rate goes down a bit. Whilst between 30 to 40, our pregnancy rates really drop. And therefore, as a routine, we do the progesterone levels 1 day before the embryo transfer. If we find the levels too high, we don't do the embryo transfer. And if it is less than 10, then we supplement it with an extra dose of progesterone and then carry on the embryo transfer. The bioavailability of different progesterones to different routes is different. And what we must remember is, if we do a blood test to know the progesterone level, it will be very difficult to assess what is happening at the endometrial level. And therefore, for us to understand is what is going on at the plasma level, at the endometrial level, it's important for us to know what is the plasma level of that progesterone. And what we find is anywhere between 40 to 100 milligrams of progesterone is needed intramuscularly. The only objection, it causes a lot of pain, it causes abscess, sometimes redness, and this is something which women don't like. Whilst orally, it has been shown that, really there's not much evidence for the oral, but then vaginal is compared with injectable, it has been shown that it can give you fairly good results. So serum progesterone levels, this is the study which I was referring to. They do it 1 day before. This is our experience, same as this study, wherein they have rescued the FET group. First group was the one which is in blue bar, where only vaginal progesterone was used. And in the second group, which is a green group, wherein the vaginal progesterone is supplemented with subcutaneous progesterone on the day prior to ET. And you find that when that is done, it definitely gives you better results. And so this is counted as an opportunity window for you to improve your pregnancy rates if you find that the progesterone is low. So the is at this point in time, we still have difficulty in understanding the endometrial transcriptome. We are not yet getting it into clinical practice, and therefore we are not able to measure the progesterone at the endometrial level. Now, if there is a normal progesterone and you still have something like a luteal phase insufficiency, so there, or that progesterone doesn't seem to be working for that patient. So then people use adjuvants, and there are many adjuvants being used for which we still don't have enough evidence. And therefore, if I have to summarize my talk, I would say that there is evidence on the following things. If the optimum, to get an optimum luteal phase support in an FET cycle, it differs depending on level on the endometrial preparation used for FET cycles. That's level 1A evidence. There's no significant difference found in clinical efficacy between natural modified, natural or programmed endometrial preparation protocols, level 1A. Then in natural or modified natural FET cycles, additional luteal phase support does not improve outcomes based on limited data. Due to absence of corpus luteum in programmed FET cycles, luteal phase support must definitely be provided. Now, all these are level 1A evidence. And then there is no consensus regarding the type and duration of optimal progesterone support for programmed FET cycles. Based on studies achieving a minimum threshold serum progesterone levels between 9 to 10 during the mid-luteal phase in programmed FET cycles helps in improving clinical outcomes, level 1A. For luteal support in programmed FET cycles, 180 milligram per day vaginal progesterone gel or anything like 50 to 100 mg per day progesterone intramuscularly provides similar clinical efficacy, and that is level 2B. Currently, there is insufficient data on oral dydrogesterone administration for the luteal support in FET cycles. Now, this is quoted in December 22. So, I think this is what I would like to say, and this is what I would summarize my talk. And thank you very much for having invited me, and I'm happy to be here. I'm sorry for this little inconvenience of not being able to project my slides fully on the screen. So please excuse me for that. Thank you very much, Madhuri, for having invited me to this session.
Thank you, Duru ma'am. That was a fantastic, awesome, very difficult topic actually. Luteal phase support, you covered it very well, all the studies and data and trials. So I'm sure everybody's got a lot of take-home messages with this talk. And if there are any questions, there are many questions. Is it possible for you to put the answers in the chat box? And I can have chairpersons to speak. Dr. Madhuri Patel, you want to say something?
No. So I wanted her to do this talk because I'd heard it when I had given it to her earlier also, and she'd done a very good job. And I think it has a lot of take-home messages, and therefore I requested her that probably, she would be the best person to do the talk.
Okay. To get a stature of her person to speak here, it's really incredible, madam. Thank you so much.
Please don't say that, because I've been part of ICOG, I've been part of everything. So please don't say that. I'm happy to be here. And only thing is I requested Madhuri that I have to leave by 6 because I have guests coming home for dinner by 7 and I need to go reach home. So that is why I requested Madhuri to do that.
Thank you.
Thank you very much. Maybe in the chat, I don't think I'll be able to put the answers right now.
No, I will answer. I'll answer those. No issue.
Yeah.
You can.
Okay.
Yeah.
Yeah. Is it okay if I leave?
Yeah. You can leave. I'll answer questions.
Okay, fine. Thank you so much. Thank you.
Thank you very much.
Thank you.
For all the delegates who are again putting, the recordings will be available on ICOG website in a week's time. It will be available for 2 or 3 days, so you can watch all the recordings later. Yes, Sandhya. Please go ahead for the next session.
Ma'am, we have a Q&A session. Are we supposed to have?
Next session, please start.
Okay, okay. So with this, we move on to the next session. And the next session is on managing ovarian stimulation in difficult situation. And for that, I have two chairpersons, esteemed chairpersons with me, Dr. Manjushri Boob and Dr. Nilesh Balkavade. Dr. Manjushri Boob, she's a gynecologist, fertility specialist, and she has done a fellowship in IVF. She has there are many credentials, but I'll read a few of them. She has organized state level FEMCON 18 conference on IVF at Amravati, organized many free fertility and IVF checkup camps, worked as a president, vice president, secretary, and treasurer for OBGY Society Amravati, and she has many publications to her credit. And she has multiple awards to her name. To just name a few: Vigyan Vardhan, Best Paper Award FOGSI, Best Poster Award FOGSI, Dr. Mudliar Award Best Academician, and Nari Samman Award by Pratidin Akbar, and Star IMA Amravati Award. Welcome, ma'am. Our next chairperson is Dr. Nilesh Balkavade. Yeah, so Nilesh Balkavade sir is a very, very active member of POGS. He's a young, he's inspiration to all the young gynecologists in Pune here. He's a clinical head and fertility specialist at Oasis Fertility Pune. He was a chairperson of FOGSI quiz committee in 2021. He is still the quiz committee chairperson from 21 to 25. Second joint secretary for the AMOX conference, which we had this year. Treasurer of MSR Maharashtra chapter and he was awarded the gold medalist at the MD examination from in Solapur. Winner of FOGSI Dr. Usha Krishna Quiz 2009 West Zone Nagpur. Best debutant POGS Dr. Smita Zog Award in 2014-15 by POGS. Dr. Shirish Daftari Award for Original Research by POGS 2020. The list is endless, sir. And he has many publications to his credit. Welcome, sir. So now I request Dr. Manjushri ma'am to please introduce our first speaker, Dr. Meenu Agarwal.
Excellent evening to one and all. Can I have her CV? It's a proud privilege to be part of this ICOG certification program. And I must congratulate Dr. Meenu Agarwal, Dr. Madhuri Patil ma'am, and also FOGSI Lewis sir for giving this opportunity and for making us a part of this great program. And congratulations, Meenu, you are doing wonders and it's really great. So I am going to introduce one dedicated, devoted and disciplinary in the field of endo-ART, very good friend of mine, Dr. Meenu. And to her, she is a president of Pune Obstetric Gynec Society. She is chairperson, Imaging Science Committee, FOGSI 2018-21, elected as Secretary General for International Society of Gynecological Endoscopy. She's joint treasurer to Maharashtra chapter of IFS. She has edited a book on the Trocar, a prestigious international journal in gynecology. And I think it will take 15 more minutes to introduce you, Meenu. But I think her talk will speak all her credentials. So we present before you Dr. Meenu Agarwal. Her talk is asynchronous cohort during stimulation. Its course, cause, effect, and management. Really, we all have this practical dilemma, especially with antech cycle, that some follicle may be at 16, 18, and some are at 2, 10, or 12. So please go ahead, Meenu.
Surely. Thank you very much. Thank you for this kind introduction. And this is a little out of the way topic that I shall be speaking on. So thank you, first of all, Dr. Madhuri Patil ma'am, Dr. Sarita Bhale Rao ma'am, and of course, the President Secretary of both FOGSI and ICOG. So my talk today is asynchronous cohort during stimulation. Now, when we talk about stimulation, stimulation by itself is a state of the art that we need to stimulate in such a way that we don't overstimulate and we don't understimulate. So we have to be very, very careful. And one size does not fit all. So I cannot say, okay, you use this one protocol and that will be fantastic for everyone. So it does not happen that way. So we need to understand, we need to individualize the STIM protocol, and at the same time, we need to understand the fine nuances of stimulation. So when I talk about asynchronous cohort, what is asynchronous cohort? There is number one, there is no definite definition of asynchronous cohort. They say if there is less than 50% M2s that you get out of whatever number of follicles, or you get less than 3 M2 oocytes, that probably is the asynchronous cohort. When we look at this particular graph, which we all studied, I was in Armed Forces Medical College, and uh, so this diagram was actually put up in our, in our clinical room, learning room. All these basic diagrams were put in there. So when we look at this particular diagram, we see that on day 2, we have these antral follicles coming up. This is day 2 ultrasound. 2 to 5 millimeter size follicles. They are seen on both the sides. We may see 4, 5 on one side, 2 or 3 on the other side. So by and large, these are the follicles and we call them the antral follicles. So what we understood in our medical college was these antral follicles are coming from the luteal phase of the previous cycle. They were not responding to the gonadotrophins initially, but in this ongoing cycle, this is when they will respond to the FSH, which is going to rise in the follicular phase. So when there is a FSH rise, one follicle will grow bigger, and this follicle, which is the dominant follicle or the selected follicle which becomes the dominant follicle, in turn will produce estrogen. This estrogen will give a negative feedback to the HPO axis that we are enough, we don't need more FSH. So the FSH will become less. Because the FSH will become less, in the sense the negative feedback of estrogen, these smaller follicles will die out, and this one follicle will continue growing, because this has become, this is a selfish follicle, intelligent follicle, and this is producing also its own FSH receptors and can grow with even smaller amount of FSH. And then finally, at some point of time, it gives a positive feedback for the LS surge, and that is when there is ovulation. So we thought this is the ultimate thing, and we have everything, we are sorted, we have learned. But then why do the follicles become asynchronous? So this is something that we started realizing when we started doing IVF cycles. So what are the various theories? Now we thought that all these follicles are recruited on day 2 of the cycle. Then the theories came up saying that it is not day 2. Their follicles are continuously recruited throughout the cycle. Okay, and from this continuous pool of the recruited follicles, one follicle will grow in the early follicular phase, which will cause the ovulation. And this follicle is selected because at that point of time, at that day 2, day 3, day 4, this is at an optimal stage of maturity, and this can respond to the rising FSH at that particular time. Then there is something called a follicular wave theory, where they said it is not just one wave which is coming. Day 2 pe antral follicles aaye, they grew, one follicle grew and the others died out. It became a corpus luteum or corpus albicans, depending on whether the woman becomes pregnant or not. And again, in the second cycle, the same thing is coming up. They say, this theory says that there are synchronous growth of the follicles which are coming at regular intervals. It can be twice in one cycle, or it can be 3 times in one cycle. So you see over here, so this is a follicle a wave which has come, and then there is another wave here in the luteal phase. Or there can be 2 waves in the follicular phase, followed by again one wave in the luteal phase. But these luteal phase grow, they do not grow, they do not form a follicle. So even the two follicular waves, only one wave will make a dominant follicle and the other wave will just die out. So they say in 2/3 of the women, they have at least two follicular waves, and the rest 1/3 of the women may have three follicular phase. So we are now confused. I'm sure I have confused everyone else as well over here. So just when we thought that we had it all sorted, worked out, we lost it again, and we now are trying to say how we can utilize this asynchronous, why this is happening, and how we can utilize this particular theory, which is a cause of the asynchronous follicle development, to our advantage. So in the major waves, like the one which comes in the follicular phase, there is a dominant follicle which either regress or ovulate, and in the minor waves, there is no selection of the dominant follicle. So the traditional concept that we had learned about female reproductive physiology and the foundation of ART, it has changed a lot over the years after we realized that there are multiple follicular waves. So before that, we must unlearn. जो भी हमने सीखा है, we should unlearn and then we must go ahead. Now, this was another paper about the ovarian follicular waves during the menstrual cycle. So what are the clinical applications of these waves? One is that we can go for dual stimulation protocol. What is dual stimulation protocol? First cycle, we stimulate. We have one wave which is coming up. So we start from day 2, we stimulate, go for an antagonist protocol with an agonist trigger. You retrieve all the oocytes, mature oocytes, very small follicles. Suppose you have, like Dr. Manjushri said, we may have 2 big follicles and 3 or 4 small follicles. AMH is 0.9. So we only retrieve the bigger follicles, leave the smaller follicles, wait for 2 or 3 days, and we again start the stimulation. And the second time, we can also give either the agonist or we can also use the HCG trigger. So that is the advantage of the dual 2 waves in a dual stim protocol. Now, she's a 35-year-old lady, primary infertility for 2 years. She has failed 2 IUI cycles. AMH is 1.1. BMI is 25. She has 3 to 4 AFC on each side. Male factor is normal. She was started with FSH, recombinant FSH 225 from day 2. On day 6, we have one follicle, 16 mm, 2 or 3 10 mm. Again, on the right side, 14 mm one follicle and 2 or 3 less than 10 millimeters. So essentially, we have one leading follicle on each side. Her E2 is 150 nanogram per ml, P4 is 0.9. So what to do? Should we cancel the cycle? Should we convert the cycle to IUI? Suppose we have cancelled the cycle, how to manage this patient? This is a asynchronous follicular growth. She does not have an excellent AMH. So what to do in the next cycle? So I think this Bologna and the Poseidon group both have already been discussed, and we understand that we have to put the patient, whether she is a hypo responder or she is an expected POR. Now, this particular patient is an expected POR. So whether she is less than 35 or more than 35, and hypo responders where the reserves are good, but they do not respond. Again, whether they are less than 35 or they are more than 35, and they have found that the low prognosis patients are group 2 and group 4. That means when the age is on the higher side, those patients do not do well as compared to patients who are younger in the age. Now, how to manage this patient? We discussed that case, how to manage these patients. We can, number one, of course, cancel the cycle. Then we can go for maybe put her on one cycle of oral contraceptive pills. then start. I know Dr. Madhuri Patil will not agree to it because yesterday we discussed and she said there is no point in putting them on oral contraceptive pills. I respect that opinion. We can increase the starting dose of gonadotropins. We can change from FSH to HMG. Can we add a low dose SCG to FSH? Can we add micronutrients, nutraceuticals to the lady? Can we do priming? So we will discuss both estrogen and progesterone priming. And of course, can we start her on antagonist? First 3 days give antagonist and then start with the stimulation. Can we change the protocol from antagonist protocol to long agonist protocol? Can we go for flare-up protocol or can we go for a dual stim? Take those 2 eggs and go for a dose, again start the stimulation. So these are the options that are mentioned, and we do follow many of these options in our clinical practice as well. So now how do we do the estrogen priming? Now we understand that whenever we give estrogen to the patient, so what do the estrogen do? It goes to the pituitary and it suppresses the FSH release. Okay, so this is a negative feedback for FSH. So we do not want FSH too early, especially in poor responders. So what we do is we start oral estradiol valerate. Now hemihydrate also is coming up and a lot of people are using that. From day 21 of the previous cycle until day 3 of the menses. You can also continue it till the time of ACG. So now luteal phase FSH will start rising for the second wave, and at that point of time we have given our estrogen in the luteal phase of the previous cycle, which will suppress the FSH. It will increase the receptors, and then on day 3 we start her on gonadotropins, take her for antagonist protocol, and we can either go for a fresh embryo transfer or a frozen embryo transfer. Again, as I said, it can also be pre-treated with OCPs, but the OCP should not be given for more than 21 days, and preferably you give it in the luteal phase. That means give it only for 10 days of the previous cycle. What else we can do? We said we can change from FSH to HMG. Maybe start with a higher dose. There are some pharmaceutical molecules where they have added small dose of SCG to HMG, and they do claim that these patients respond better, especially in poor responders. Can also go for an agonist, long agonist protocol, or change to the flare-up protocol. So no antagonist, long agonist, in my opinion, means in my practice, I have found it works well. We do change. Dr. Sandhya will agree to it. We have worked together for a long time. Then switch to a flexible progesterone protocol. तो इसमें क्या करते हैं? We start with antagonist only. But if we find that the follicles are not very synchronous, then you add progesterone. Obviously, it is going to be freeze all. And with the progesterone, then you change it to flexible. You are not starting progesterone from day 2, but from day 5 or day 6. So that is called flexible progesterone suppression protocol. So that can also be used. Then agonist-antagonist conversion protocol with estrogen priming and the dual stim protocol. Now, antagonist cycles, sometimes we can have a heterogeneous follicular development, and these cycles we do understand that some times they have lower maturation rate as compared to agonist. There was a time when we said that the antagonist cycle will give us less pregnancies. However, now antagonist cycle has become more, and I will just finish in 1 minute. And then, of course, duo-stim protocol, where we start stimulation again in the luteal phase. And there was this landmark paper in last ESHRE, where they first did the luteal phase stimulation and then did the follicular phase stimulation and did a transfer in the fresh cycle. So very simple thing actually, but it was a landmark paper and they also got the first prize. We can also treat these patients with CoQ10, DHEA, testosterone gel. All these are also options. Should we delay the SCG? If we see only 2 good follicles, rest are small, but studies have shown that delaying SCG to allow further growth of medium-sized follicle should be discouraged, and that does not improve the pregnancy rates. I think this I can again skip, and thank you very much. And if there are any questions, I can answer them in the chat box. Thank you very much.
Thank you, ma'am, for the wonderful talk as always. May I request the chairpersons to give their comments? Nilesh sir, Manjushri ma'am.
Ma'am, Nilesh sir is not there. Manjushri ma'am is there.
Manjushri ma'am, requesting you to give your comments.
Yeah, it was really an excellent and a different insight by Dr. Meenu Agrawal ma'am, and really unlearn the things already learned and go again into the intricacy of ovulation induction. That is really a path we all are seeing ahead and a ray of hope. For poor responders also, we can have duostims because of this, and secondly also we can have a multiple oocyte retrieval, like maybe 3 in conjunction, like maybe a luteal phase, then follicular phase, and maybe wait for a cycle and again a follicular phase to have a because egg donation is becoming a real problem in our country nowadays with the new ART law. So I think it is a ray of hope for ovulation induction. Thank you so much, Dr. Meenu, for an excellent presentation.
Thank you. Thank you very much. Thank you, Dr. Manjushri. Thank you.
Thank you, ma'am. Thank you, ma'am, for your comments. Nilesh sir, has he joined again?
I am here.
Yes.
Okay.
Ma'am, I request Manjushri ma'am only to please introduce Gauri Devi ma'am.
Okay, it's my privilege to introduce one of my favorite, Dr. Gauri Devi ma'am, and she's the director of Gauri Hospitals, director of Reach IVF. She is immediate past president of IFS, organizing co-chairperson for 51st All India Conference of Obstetrics and Gynecology, AICOG, 2008. I think madam has started screen sharing. So most of us all know this eminent speaker who is here to present her talk, Hyper Responders PCOS. Ma'am, please go ahead. I could not read your CV because it was taken away. Because ma'am, it was taken away from the screen. I'm so sorry.
I didn't know it was, I thought it was my first slide.
Okay, okay, ma'am, please go ahead. Everyone knows you and we are eager to listen to you, ma'am.
Thank you very much. Good evening to everyone. And at the outset, I would like to thank Dr. Madhuri. I had used some of her slides. Thank you. So today I shall be talking about hyper responders, essentially as is in PCOS. Why is PCO different? Because there is a great sensitivity to gonadotropin stimulation. The minute you give gonadotropin, there is an explosive growth of the follicles, and that is why PCO, we are very careful. There are elevated LH levels, androgen excess is there, insulin resistance these patients have. There are multiple follicles, and some of these ovaries are very resistant to stimulation. Now, you have, when you stimulate these patients, excessive ovarian response, there's low fertilization rate, and we all know we get many immature oocytes. You might get, even if with a normal stimulation, 30 or 40 oocytes, but almost 20 of them are immature. There's a reduced cleavage rate, low implantation rate, and for some reason, there is a higher miscarriage rate, as high as 28%. Now, what is it that we are trying to achieve when you do the stimulation? We have to maximize the beneficial effect by giving a singleton live birth that term, minimize the complications and risks. Why? We want to avoid doing a cycle cancellation. So risk of OHSS, poor response, etc. Multiple pregnancy to be avoided and OHSS to be avoided. Now, select the correct stimulation protocol. That is what is important. We have to individualize it. And for that, we take note of age, FSH, AMH, AFC, and BMI. All these are taken into consideration when we stimulate these patients. Now, coming to the prediction of response, when you see, you will find that this is the ESHRE guidelines. Prior to the start of the stimulation, we have to do a risk assessment of high response, because once you assess the risk, it's easy for us to decide which protocol to use. For predicting high and poor response to ovarian stimulation, use AFC and anti-Mullerian hormone. It is recommended more over the other ovarian reserve tests. This is the ESHRE guideline. And quantitative markers of ovarian response, they do not reflect the woman's fecundity. We go more by AFC and AMH. Now, it is very important to individualize the stimulation, because when you, for the optimum outcome, when you use the stimulation protocol, which is ideal to that particular patient, you will minimize the complication, you will achieve what you want, and you will get a good number of oocytes. Now, how do we overcome this problem? Mild stimulation, oral contraceptive pre-treatment, agonist vis-a-vis antagonist, agonist to trigger ovulation, metformin and other additives, freeze all the embryos. Very rarely, when needed, use IVM. Now, this low step-up protocol, as well as the next slide I use, it is essentially used for IUI protocols, not for IVF. We start with a low dosage and slowly increase so that you are getting only a monofollicular growth or maximum 2 or 3 follicle. We do not want an explosive sort of a stimulation there. Then you can use oral ovulations with gonadotropins. You give it for 5 days and you can give gonadotropins every day or alternate days, depending upon the ovarian response. Because the minute you give gonadotropin, they're just going to flare up. So be careful. You might even give alternate. And I still remember Dr. Chakravarti telling that you give the oral ovulation and give only 2 doses of gonadotropin. Day 4 for development and day 9 for further growth. So like that you can use in IUI. What about IVF? What do they say? Now coming to oral, I'll go towards the IVF. To using OCP as a pre-treatment, what are we trying to do? That is, LH is usually raised. So what we are doing is a normalization of a LH-FSH ratio, reduce the ovarian androgen concentration, and you try to attenuate the initial flare response to GnRH agonist if you give. Now, high responders, addition of clomiphene citrate to gonadotropin in stimulation protocol is probably not recommended for predicted high responders. This is the ESHRE guideline of 2019. They also said that there is insufficient evidence to recommend the addition of letrozole to gonadotropin in stimulation protocol for predicted responders. What about FSH vis-a-vis HMG? Would you like to go for a recombinant FSH or you can go for a HMG? The recommendation, and that also with strong evidence, use of recombinant FSH and highly purified FSH for ovarian stimulation in agonist protocol is equally recommended. The use of recombinant FSH and HMG for ovarian stimulation is also equally. Here there is a strong evidence. Okay. Now, GnRH antagonist. Let us see with agonist and antagonist. Antagonist protocol is recommended for predicted high responders. We all know why it is so. And if the agonist protocols are used, a reduced gonadotropin dose is probably recommended to decrease the risk of OHSS. So in these patients, we prefer to use antagonist because by using an antagonist, you can use agonist as a trigger. So the prevention of OHS is there by using agonist as a trigger. So, according to the ESHRE protocol, ESHRE guidelines, GnRH antagonist protocol is recommended for PCO with regards to improved safety and efficiency, and a gonadotropin antagonist protocol is referred in these patients. To this also, it has an upper hand over the agonist protocol to reduce the duration of stimulation, total gonadotropin dosage, and incidence of OHSS. What about the trigger? Would you like to give HCG? Would you like to give recombinant HCG? Or would you like to give agonist trigger? So since we are using an antagonist, an agonist trigger is recommended for final oocyte maturation in women at risk of OHSS. It's a very strong evidence. So when you are giving an agonist trigger, what we do is to freeze all this thing to eliminate the risk of late onset OHSS. So freeze all the oocytes and give agonist. And one more thing that maybe I'll tell you regarding that later. Now, so how are we going to segment this? Use gonadotropin with an antagonist protocol, use agonist as a trigger, then vitrify all the embryos and do an FET. A freeze-all strategy is recommended to fully eliminate the risk of late onset OHSS. Prior to the stimulation, we have to do a risk assessment as to will this patient hyper-respond? Now, to increase the effectiveness, improving the pregnancy rate and increasing the receptivity. Sorry, this is. And use of oral progestin to, sorry. So you will see that there's a decreased endometrial receptivity related to endometrial advancement as a result of controlled ovarian stimulation. So all this, once you freeze all and then you do it, there is a prevention of OHS also. There's a decreased incidence of ectopic pregnancy. Then coming to newer protocol, we can use PPOS, which my previous speaker was speaking about. You use progestins, and this progestin, they have found that the live birth rate was comparable to your natural cycle or antagonist cycle or short agonist cycle. Now, one can use, they were comparing MPA with ganirelix. This is the antagonist cycle. They found that clinical pregnancy was very much comparable statistically. You can say it is not a non-inferiority trial. And in our setup, all the donor cycles we do with PPOS because one, it is less expensive, two, no chance of hyperstimulation. Then different progestin that used. In my setup, we always use medroxyprogesterone acetate. There are studies with dydrogesterone 20 milligram. Dynogest have been used, and also even some have used micronized progesterone also. But we use MPA or medroxyprogesterone. The use of, but ESHRE says use of progesterone for LH peak suppression is probably not recommended, but if applied, progestin can only be used in the context of non-transfer cycles. So what made ESHRE say it's maybe because when we give progestin, what do we see? That cycle, we cannot do a transfer because the endometrium goes haywire. You will have to wait for 1 month. sometimes, we might have to wait for 2 months because the endometrium doesn't come back to normal. That is the only reason why when you give PPOs, don't do any transfer. There are a number of studies which have come. This is one of the latest studies where they tried it, and they found that this yields low euploidy in older patient undergoing IVF. There's one more study, which is a meta-analysis of control trial. This came in 2021. And what is the embryo outcome in PPOs? In the older age group, what they found was that those who are more than 38, the blastocyst formation was lower than that of antagonist group. And the embryo euploidy rate was only about 20% the PPOS group. In the younger group, less than 38 years, there was no significant difference in the blastocyst formation rate or euploidy rate. So they recommend that more than 38 years, avoid giving PPOS. Now comes the newer stimulation. This is a late initiation of stimulation. These are very few studies in this. Here, what it is that in the antagonist, what they do is they use a long-acting antagonist, what is known as a digarelix. It's a bolus injection of digarelix, which is they have used in both ways. They have given it on the 24th day of the previous cycle, and then starting gonadotropin. Once the period starts, starting the gonadotropin, they have done. There are not many studies. Whatever is available, I'll show you 1 or 2 slides. This is one slide that is there. Group A was classical. They studied about 59 women, Group A and Group B. Group A is the antagonist, Group B is the long antagonist. And what they found was that the pregnancy rate was, long antagonist as a little more, statistically significant more number. But somehow there are not enough studies to support. I think we require, as they rightly said, more studies are needed. Now, so to prevent OHSS, what do we do? Identify high-risk patient, use low-risk treatment, and specific measures in individual cases. So, avoid giving an HCG. This will prevent your early OHSS. And mind you, when there are too many follicles coming up, after giving the agonist trigger also, if we find that it is going to go, what we do in our setup is to give an antagonist for 3 days more. That will give us complete luteolysis. And to prevent late OHSS, don't transfer in that cycle. So no pregnancy, no late OHSS. So the incidence varies mild to moderate 0.6 to 14%. And severe OHS is very rare, 0.2 to 0.5%. In our setup, we are completely OHSS-free clinic for the last 6 or 8 years. We have hardly had any severe or even moderate. Mild, sometimes we do get. Now, what are the risk factors? When the AMH is very high, more than 4 or 5, rapidly increasing level of estrogen, optimum cut AFC is many more. And when you're stimulating, besides that leading follicle, you find a lot of intermediary and small follicle. And these are the ones which just explode when you give a HCG or when you give a trigger. So these are the things you should be careful and watch as a risk factor. So how do you do a low risk treatment? You will mild ovarian stimulation. That means don't give too much of gonadotropin, add antagonist, use agonist as a trigger. Now, some specific measures, you see, in a PCO, when you're stimulating that time, you cannot do LOD and all. But if you find really large ovaries, people have tried outside to stimulate. AMH is very high. You see the LH, sometimes you get LH24 and you see huge ovary. In these patients, if you do a LOD, put 3 or 4, you will be able to reduce the androgen and LH level a little. Then later, your stimulation may be better. And some of these patients are known to conceive on her own also. You can use metformin. It helps both ways because insulin resistance is reduced. Early abortions, it is said to prevent, and also it's said to prevent OHSS if you are given the previous time. IV albumin, IV infusion, still we use it. The evidence is only grade C. And cabergoline, of course, we are using 0.5 milligram daily from the day of pickup for about 10 days. That will really helps. Where aspirin, no evidence. And methylprednisolone, some people give in PCO 16 milligram per day, starting from day 6 of the oocyte retrieval and tapered by day 30. And this is said to be effective. Now, some specific measures, some people do coasting. Really, there is no evidence. Cycle cancellation before HCG administration. Better to avoid that. And one type of FSH versus other, there is no evidence. Follicular aspiration, no evidence. Luteal use of luteal antagonist and letrozole, there is no evidence. IVM, yes. So these are two types where you are trying to stimulate, and we have done 10-day stimulation. All the follicles have reached 14 to 15, and they refuse to budge. You try 1 or 2 more days, they are standstill at that time. That is the time when one can do an IVM, but this is associated with lower pregnancy rate. We are not doing IVM in our setup. I'm sure some of you might be doing it. How do we prevent? GnRH antagonist protocol coupled with agonist trigger. It is efficient, it is safe, it is simple. And best method for preventing OHSS. So my take-home message would be improve efficacy, safety, and cost effectiveness of treatment. Identify the risk factors, choose the right protocol, choose the right trigger, prevent OHSS, and in case if it happens, treat and identify, diagnose it in time, and treat it in time. Thank you very much for a patient hearing.
Thank you, ma'am, for a wonderful presentation. I request the chairpersons to give their comments. Nilesh sir and ma'am.
Dr. Nilesh is there. Is he there?
He was there, but I can't see him.
Okay. It was super excellent talk by ma'am. And there are really few new things which we all have, and carrying home messages like long-acting antagonist given 3 days more post your pickup to decrease the level of or chances of OHSS, later half of OHSS, later part of OHSS. Especially in the group where either many AFC is very high or AMH is very high, more than 5 or like that. Definitely segmental IVF is, and no OHSS in any clinic. OHSS free clinic with no HCG trigger, and having a segmental IVF, that is stimulation and then pick up, resolve, and then transferring is a key to all OHSS free clinic. So definitely hyper responders PCOS will be managed so well after this talk of Dr. Gauri Devi ma'am. And once again, thank you to the organizers for giving this opportunity. Thank you once again.
Thank you, ma'am, for chairing the session, and thank you for giving your comments. With this, we move on to the last session now, which is on what's new in ovarian stimulation. And for that, I call upon the esteemed chairpersons. Our first chairperson is Dr. Rita Bakshi. She's done a post-graduation from Safdarjung Hospital. She has a diploma in ART from KK Hospital, Singapore, and diploma in endoscopy from Kiel, Germany, WHO fellowship in Gynae Onco from AIIMS, Delhi. She's a chairperson of RISA IVF, Honorary Professor ART Rohilkhand Medical College. She is the principal investigator of clinical trials with a number ongoing of research trials, and she is the chair faculty at Institute of Reproduction Fertility Training, senior consultant and fertility specialist endoscopy surgeon, and founder of Adiva Group of Hospitals. She's been conferred upon her with the award of Icon of the Year in the IVF Specialist category in North Zone by the Economic Times in 2022, and also the most influential, inspiring women leader in healthcare in 22 by Medgate. Welcome, ma'am. Our next esteemed chairperson is Dr. Brajbala Tiwari. She was the president of Indore OBGYN Society in 22-23. She is the vice president of IMA Indore Menopause Chapter. She is the secretary of ISOPAP Chapter Indore. She was a joint secretary MP ISAR 22-24, organizing secretary of AMPOG 2018, organizing joint secretary AICOG 22 and ISAR 23. She is the Managing Director of Life Care Hospital Limited, Indore, Santati Infertility Rescue PD Center, Indore, and LCH Nursing Academy, Indore. Welcome, ma'am. Our next esteemed chairperson is Dr. Mohan Gadam, sir. He is not joined yet, but he will join in some time. He is a consultant at Nanavati Hospital and director of EVA Fertility and Endoscopy Center. As a postgraduate teacher and likes teaching. And he has publications on prostaglandins, tubal ectopic pregnancy, VBAC, and tubal recanalization. Welcome, sir. So now I request our first chairperson, Dr. Rita Bakshi, ma'am, to introduce our first speaker, Dr. Asha Bakshi.
Very good evening, Dr. Asha. It's my proud privilege to be introducing Dr. Asha. She's the lead consultant at Dr. Asha Bakshi's Fertility Center associated with Motherhood Hospital Indore, Vice President-elect 2022 West Zone, Joint Secretary SAR 2021, member of West Zone, founder chairperson MP ICOG, MP ISA, chairperson FOGSI Infertility Committee 1719, member ICOG Governing Council 1821, and I think the list goes on and on. It's a pleasure, Dr. Asha, to be introducing you, and I'm sure it'll be a pleasure hearing you.
Thank you very much, madam, for the kind introduction. And I would like to thank the organizers and especially Dr. Meenu Agrawal and Dr. Sandhya for hammering me all the time till last moment. And just, I think, few minutes ago, I could just finish the presentation, but because somehow it missed, so I had to. But now I'll share my screen and let's go ahead. Yes. So I'm going to talk on newer protocols for LH suppression in ART cycle. Most of my work has already been done by Dr. Gauri in the previous talk, and that would make the job very easy. So first of all, why there is a need for pituitary suppression in ART cycle? And we have been trained way back in 1980-83, and I was with Dr. Sadhna Desai, and that time we were collecting 24 hours urine, and many a times the pickup would come at midnight, and this is how it used to be. But thanks to understanding of physiology and pharmacology, that people understood that if we could suppress the LH, then we could control the cycle and we can do the pickup in proper time and when the follicle is really mature. So premature LH surge is a major cause of cycle cancellation due to controlled ovarian stimulation in women undergoing IVF without intervention. Thus, it should be primarily prevented. And now, before that, let's understand what is GnRH. So GnRH, that means gonadotropin releasing hormone, is encoded on a single gene located on short arm of chromosome 8. And it is produced and secreted by a group of neurons located in hypothalamus. These molecules are transported to pituitary by intricate work of capillaries. And it is a decapeptide with a short half-life. It regulates production and release of both LH and FSH in gonadotropes of anterior pituitary, and it plays a key role in functioning of hypothalamic pituitary axis. So, and it is a pulsatile hormone from hypothalamus. It acts on pituitary and thus LH and FSH are secreted, and LH in turn stimulates the theca cells to produce androgen, which is then converted to estrogen. Upon achieving a critical level of estradiol, it begins to have a positive feedback on LH release, which results in LH surge and thus ovulation. I think you all understand this from your basic physiology. So, and this is the pituitary, and on pituitary, this is a hypothalamus from where the GnRH analog, from where the GnRH is released. And these are the GnRH receptors. So when initially a GnRH analog tries to desensitize it, then that time a flare-up effect occurs. So that we have to understand. And here, immediate, if our receptor is blocked, then immediate effect will be there. So there won't be any flare-up effect. So, and this is how the antagonist acts. So downregulation is, we all understand that in the previous cycle, during the luteal phase, already there are the LH levels. And when you give GnRH analog, then initially there will be a flare. And then by the time there is menstruation, this flare will, all the LH levels will go down. And by the time we are going to do oocyte retrieval, the LH levels are suppressed. So this is how the GnRH agonist acts. Whereas GnRH antagonist, it is when there is period, when there is menstruation, then just after the menstruation on 4th or 5th day, GnRH antagonists are given and they start blocking. So initially there is LH, but in the follicular phase, and then this is being blocked. So this is how the GnRH antagonist acts. So agonist, the aim is to aim of introducing the agonist to IVF protocol was to prevent the premature LH surge. And GnRH analog is released in a pulsatile fashion, but a continuous supply of GnRH suppresses gonadotropin secretion by desensitization of the gonadotropes. And what is upregulation? Upregulation is an increase in number of receptors that amplifies the synthesis and release of gonadotropins. This occurs during pulsatile GnRH release or its superactive agonist. So initial upregulation of receptor facilitates the ready synthesis and release of large amounts of gonadotropes. And this is the flare-up effect. And we have to understand this because this flare-up effect has been utilized especially in patients with diminished ovarian reserve. Otherwise, it is harmful because sometimes it may lead to asynchronized follicle cyst formation. But in reduced ovarian reserve, it is quite useful. Now, downregulation. Downregulation is desensitization of the receptors. So when GnRH receptors are exposed to GnRH agonist for a prolonged period, the cells lose their ability to respond to the stimulus with original sensitivity. The process is rapid and reversible, and it operates at both receptor level and by post-receptor modification. So there are various traditional protocol. The most important traditional protocol that we have used for so many years, maybe for more than 20, 25 years, and that is the long protocol. And in this protocol, we start the GnRH analog injection on day 21 of the previous cycle. And the initial flare-up effect of the GnRH agonist is followed by desensitization and downregulation of the pituitary gland. It is given for 2 to 3 weeks, and once, like when during menstruation, almost the flare-up effect is gone and down regulation has already started. That time we check the estradiol levels, and usually we aim at estradiol levels less than 50, and we check whether the endometrium is thin or not, and there aren't any cysts in the ovary. So this suggests that now the LH levels are very low and down regulation has occurred. So the stage is ready to start the gonadotropin. So after the down regulation, gonadotropin is started, and this protocol is associated with high oocyte number and clinical pregnancy rates. So this is what we have always been using, and I think most of us have very good experience with this protocol. So, but what then there is another way one can use the GnRH agonist, and that is the flare protocol. And this is usually found to be useful in patients with reduced ovarian reserve, because initially when you give after the spontaneous menstruation, then it will give rise, there will be rising FSH and LH, and that may give you reduce the doses also and give you better follicles. Then there is one protocol which we use with GnRH analog, and that is ultra long protocol. And here what happens is you can give a depot preparation of GnRH analog, and especially it is very useful for the patients of endometriosis with severe adenomyosis, where you can give it and then transfer the frozen embryos. Then long-term pituitary down regulation before frozen embryo transfer would improve pregnancy outcomes. I think most of us know about it. So then what was the problem when we were so happy with this long agonist protocol? What was the problem? I think we all are always in search of something more comfortable, more patient friendly, and that's what it happened. The disadvantages of long protocol were that longer pre-treatment period was required. Initial flare-up of FSH and LH may lead to ovarian cyst formation. Excessive follicle selection may lead to high incidence of ovarian hyperstimulation, especially in PCOS patient. Dr. Gauri has already mentioned. Oversuppression in poor responders, requiring a higher dose of gonadotropins or a poor response. Higher incidence of multiple pregnancy, luteal phase support is required, increased total gonadotropin per treatment cycle, higher cost and daily administration. So naturally, people were on a lookout and they found this antagonist. So especially around the year 2005 or so, antagonist was introduced, and it was so friendly, and all the infertility specialists liked it so much that slowly, gradually, they started replacing their long protocols with GnRH agonist protocol. So it was at the beginning of this decade, it was started, and a series of theoretical and evidence-based advantages supported its use. So GnRH, introduction of GnRH antagonist provided prevention of premature LH surge with distinct advantage. And the advantage was more timely suppression of LH, no symptoms associated with GnRH agonist flare, and down regulation. And the GnRH antagonists, they act by binding to GnRH receptor and prevent endogenous release of GnRH from pituitary gland. GnRH antagonist protocols are associated with immediate LH suppression. And this is how the antagonists act. And there are two ways. You can give a fixed protocol where you start on day 6, or you can do it when the follicle is 14 millimeter. And some people give a single dose of GnRH antagonist also. Though it is not very popular, most of us use the daily dose. And treatment protocol with the GnRH antagonist, this is again same thing. So advantages of antagonists are the same success rate as agonists. So you cannot say that the results of agonists are superior as compared to the antagonists. But naturally, you have to individualize your use, and you can't just say that blanketly, I'm just using antagonist, I'm just using agonist. I think most of the times people, because now the understanding of pharmacology is so good, and so that people are playing beautifully with these medications. So whenever you use antagonists, they say cancellation rate is less, reduction in duration of GnRH agonists, and reduced gonadotropins and lower dropout rates are there. And there is no initial flare-up, no estrogen deprivation symptoms, shorter treatment, reduced gonadotropin use, flexibility, administration only during period needed to suppress endogenous LH surge, lower risk of ovarian hyperstimulation, and rapid reversibility of pharmacodynamic action. So what are the disadvantages? Here what happens is initially the LH levels remain unsuppressed during the early follicular phase. So LH, estradiol and P4 both are high, all the three are high, and this may adversely affect the endometrial receptivity. Then high intercycle endogenous FSH concentration may lead to asynchronous follicular development. So that can be up to some extent prevented by giving pre-treatment with oral contraceptive pill or with estrogens. Whenever you give oral contraceptive pill, see to it that the pill-free period before you start ovarian stimulation is at least 5 to 7 days. So then came, we were still not satisfied with this. So came the new protocol, and that is PPOS protocol, progestin primed ovarian stimulation protocol. So here you don't have to give injections at all for down regulation. With GnRH analog, you were giving so many injections, almost sometimes it was coming to 21 injections. Then with antagonists, the number went down to almost 5 or 6. And now this is PPOS protocol where you start progesterone on the day of ovarian stimulation. So oral administration of exogenous progesterone beginning in the early follicular phase blocks the LH surge through progesterone instead of traditional down regulation or GnRH antagonist, and it can effectively serve as an alternative to conventional GnRH analogs. So this is how We can use various progestins. We can use medroxyprogesterone. We can even use dydrogesterone. So we, in our practice, we use medroxyprogesterone. And especially we use it mainly for our PCOS patients where it is giving very good results. So then because it is a new thing, so there will be naturally lots of research is needed and lots of experiences have to be shared. And this is one particular review article where they have said progestin, where they have been they are very convinced about PPOS protocol, and they said that it can be used in all the situations only when you are ready to do frozen embryo transfer in the next cycle. So biggest problem with PPOS protocol is that you have to always do freeze all and transfer the embryos in the next cycle. So that increases the time to pregnancy. So that is the biggest disadvantage of PPOS protocol. But otherwise, people have used it in not only in PCOS patient, even in patients with low poor ovarian reserve. So, but then there is this another study, which I think Dr. Gauri has already mentioned. And in this study, they found that PPOS protocol yields lower utility rate in older patients undergoing IVF. So if in older patients, better to go for antagonist protocol rather than PPOS protocol. And then there is another thing that people have used, and that is clomiphene, because what it was found that during IUI, there was LH suppression when clomiphene was being used. And this experience was used in IVF protocols also. So especially those who were doing minimal stimulation protocols, they were using clomiphene citrate, and they were finding that LH surge is very well suppressed when you use clomiphene citrate. So there is this another study where they have used clomiphene citrate in mid-follicular phase, and they found that the results were quite good, and it can replace GnRH antagonist or analog. So now coming to diminished ovarian reserve, that is the most trickiest ovarian stimulation protocol, because here you feel so frustrated, and I don't know what is happening, that in our practice these days we are almost finding more than 30 to 40% patients who have got poor ovarian reserve. So in these patients, you can use this knowledge in various ways, and people have used standard flare-up regimes. They have used reduced dose, micro dose GnRH agonist regime. Then they have used GnRH agonist stop regime. That means they start with GnRH agonist in the luteal phase, stop it, and then again either they use agonist or antagonist in that particular cycle to suppress the LHP. Then they have used so all these protocols have been variously used, and people have compared 3 downregulation approaches to poor ovarian responders during IVF, and what they found was microdose flare protocol for poor ovarian responders demonstrated a trend towards higher delivery rate. So these things can be used in our day-to-day practice. So then I think this protocol has already been mentioned by Dr. Gauri, and this is long antagonist protocol, luteal administration of single dose of GnRH antagonist. And that is also getting popular these days. But again, we need more studies and more results. Now, another thing which I could not put that slide, and that was use of oral antagonist in the ovarian stimulation protocol. And that will again change the scenario a lot, and that will make the IVF much more friendly. So these are the various protocols which we can use, and we can use our knowledge of pharmacology, and then we can modify and make the IVF cycles more patient-friendly and get better eggs and better results. So at the end, I would like to thank you all for the patience.
So I think that was really good, Dr. Asha. And I think all of us are so used to now doing PPOS. In fact, all my egg donor cycles, in fact, that was the last thesis topic for my IFS student also. We have done, I think, around at least 600 cycles of PPOS, and even at that tune of having 22 eggs, and never have we had a rupture. Of course, all these cycles, we understand has to be freeze all, which we are okay with now, with our freeze results being equally good. What about in between we also used ibuprofen. That was also so. NSAIDs also are being used, and we found, that at times we did use them, and I mean, I did go through the literature, and I saw that even NSAIDs can be used as an antagonist. They also prevent an LH surge. In fact, sometimes, when people ask, it's very painful, can we use an NSAID for pain? It was then that we realized that if they are using, it may suppress the LH surge, and this may, be trouble. So, I think there'll be many more molecules which will be coming. And thank you, Dr. Asha. That was really good. I think the whole thing was very good. Thank you.
Thank you.
Excellent presentation, Dr. Asha ma'am. Very, very nice. And you took everything, all down-regulating agents. And I think, yes, and NSAIDs were supposed to act as anti-ovulatory drugs. Dr. Madhuri Patil ma'am, would you like to comment on NSAIDs as down-regulating agent?
Yeah, it is said to do so, but I personally don't have any experience in that. So therefore, I would not really like to comment on something which I have not really used. So I don't know really the efficacy of that. So I don't know. I mean, if Rita
Same
is...
here. Yes, yeah. Even I have never used it.
Something about that. Dr. Meenu, can I add something about use of NSAIDs?
Yeah, sure.
So yeah, even I don't have much experience of using it conventionally in my stimulation protocols, but there is an interesting situation where it has come to our rescue sometimes. Sometimes we have referring gynecologists who are planning actually an IUI cycle, and unexpectedly they find, on day 8 or 9 of stimulation that there are too many follicles that have formed. They want to convert it to an IVF, but they don't immediately have access in their center to an antagonist. And then they call me up frantically and ask me what to do. I tell them, at least for today, you give NSAIDs. Meanwhile, while you're arranging for the antagonist to be given from tomorrow. And I don't know whether it is really the NSAIDs that have worked or coincidentally follicles didn't rupture. But in these situations, we've definitely used them and found that we were able to do the retrieval.
So I have basically heard Professor Von Wolf from Switzerland, where he said that they were not used for down regulation of LH, but they were used for postponing ovulation induction. So suppose the ovulation would have happened tomorrow, you want to give your HCG trigger. So if you want to delay your HCG trigger, then probably you could use ibuprofen. That's what I have heard Professor Von Wolf speaking about, but I'm not really aware of LH down regulation.
See,
So,
what I feel is that IVF is such a thing that we would put everything to it, and just with NSAID still there isn't much data, so we wouldn't want to use it. Maybe for IUI it is a good idea, but for IVF we wouldn't want. And if it was so good, then it would have, like antagonist. I think within 1 year, the moment the antagonist came, within 1 year everybody started using it. But such a thing has not been with the NSAID. So what I feel,
Dr. Asha, just to, this is what happened with the progesterones also. Previously, we could not imagine, but now they have taken by storm. I think it just takes, a few cycles, few people to try it well. And clomiphene, like you said, we've been trying now for especially IVF light cycle, carry on clomiphene, and that works very well as an antagonist. So I think we may be up for many more surprises as far as.
will come up, but at the moment,
why ibuprofen can be used to delay ovulation is because of its antiprostaglandin effect. And therefore, it cannot be used for down regulation, according to me, of what my knowledge goes. And basically, it can just be used to postpone your HCG trigger and delay your ovulation. That's what is my thinking, looking at the physiology of ovulation. But if you have any reference, please do pass it on to me, because I would really like to read, as ibuprofen being used as agent for down regulation of LH. Wherein the LH is really low and you can do an IVF with it. I mean, I really like to read it because I've not come across that during my, when I'm reading so many things, but I've never come across it. But what I know is that we can just delay the ovulation. Yeah.
Dr. Meenu, you're on mute.
Sorry. So we can go first. Dr. Sandhya, can you
Yes.
can
So,
you introduce the next speaker, please?
yes. So I request Dr. Brajwala Tiwari ma'am to introduce our next speaker, Dr. Sulbha Arora.
Good evening to one and all. Thanks for giving opportunity, and it's my privilege to introduce Dr. Sulbha Arora. She is having 20 years of experience in ART, and she is clinical director Nova IVF Fertility, and she had fellowship in reproductive medicine from Israel, advanced diploma in reproductive medicine from Kiel, Germany, and co-opted member of ISAR, and so many active participation. And she had been awarded with MOX Dr. Shantabai Traveling Fellowship, Mox Dr. Best Managing Committee Award. Let me read at least few words. So she's an editor for Reproductive Medicine Challenges, Solutions and Breakthrough. So she is excellent academician and having vast experience in ART. So I invite Dr. Sulbha Arora for a talk on luteal phase support individualized. Over to you, Dr. Sulbha.
Thank you so much, Dr. Brajbala, for the kind introduction. And thank you, Dr. Meenu, for inviting me once again, and Team ICOG as well. I'll start my screen sharing. Is the slides visible?
Yes, ma'am.
Yes. Make it a full slideshow.
Okay. So I'm
Perfect.
talking today about individualized luteal phase support. It's very important actually, because progesterone is such an important molecule. We'll end up using it so commonly in obstetrics and gynecology, yet there is no conventional luteal phase support protocol that we use. There are so many different protocols that you will see different clinics using, and on top of that, there are certain clinical situations where even more variation from the conventional protocol might be required. So we are going to take a look at what is normally used for luteal phase support, and then what are the different clinical situations where it needs to be changed. We know the luteal phase is the period after ovulation. That is when the progesterone hormone is secreted by the corpus luteum. It has a very important role to play because it prepares the endometrium for implantation. Once implantation occurs, the corpus luteum continues to secrete the progesterone hormone. It enhances quiescence of the uterus by inhibiting contractions. And later on, the placental shift takes place where the placenta starts secreting progesterone. If there is no pregnancy, the progesterone levels fall and the endometrium sheds. So not just is it for the secretory transformation of the endometrium, but it promotes the vasodilation, keeps the myometrium relaxed. And very importantly, there is an immunomodulatory action which prevents miscarriages. So this has also been shown with the ratio of Th1 and Th2 helper cells that is induced by progesterone. So the luteal phase defect, now what happens if this is defective? This was described almost 75 years back, but even today, the occurrence of that in natural cycles, even though there are so many risk factors, that is still debated. What concerns us more is the iatrogenic luteal phase defect that mandatorily is a part of all ART cycles. And why that happens is, now when we're doing a stimulation, there are going to be multiple follicles and lots of follicles, lots of corpus luteums that initially have very supraphysiological levels of estrogen and progesterone that overrides the natural feedback mechanism. There is going to be an initial rise and then a very rapid fall that causes a premature luteolysis and then a sudden drop in progesterone levels. That is why luteal phase is always defective in ART cycles. Like you can see in this graph, when there is a natural cycle, gradual rise of progesterone and a prolonged effect, but in a stimulated cycle, sudden rise and a sudden fall. So when you're doing an ART, all cycles will require a luteal phase support, and luteal phase support means supporting the implantation process. Now, how do we support the implantation process? You have different options. HCG was used earlier, but it is a more indirect form of luteal phase support, especially in fresh cycles. There is a risk of OHSS. Therefore, it's not much preferred. The preferred molecule is progesterone. Then there are other molecules like estradiol, but that is debated whether it is really required. And recently, the role of GnRH agonist has been investigated, but it still needs more studies to rule out safety concerns. So in this Cochrane database review in 2015, they did show that progesterone it does increase the live birth rate and ongoing pregnancy rate. HCG, even according to Cochrane database, is not much in use. Co-treatments with so many other things have been tried, but only GnRH agonists did seem to improve the outcomes. Addition of estrogen and route of progesterone did not affect the outcome. So they did conclude that progesterone remains the best option for luteal phase support. Now, progesterone, as we know, is available as either micronized or synthetic progesterone. Micronized progesterone in the form of capsules and gels, which can be used orally, rectally, vaginally, and also in the form of intramuscular and subcutaneous injections. The problem with natural micronized progesterone when we try to give it orally is that it undergoes rapid metabolization into the reduced activates, which are not, the bioavailability is very, very poor. So it just does not work by the oral route, and therefore it is preferred to be given vaginally instead. When you use it vaginally, there are gels that are available, there are capsules that are available, and there are progesterone effervescent tablets that are available. Also, the vaginal route has this unique advantage called the uterine first pass effect, where the hepatic metabolism does not take place and the drugs which are deposited in the vagina are preferentially absorbed into the target organ, either directly through the cervix or, from the countercurrent mechanism of the blood vessels. So you can see how once it is, given vaginally after 1 hour and after 4 hours of application, there is a progressive diffusion from the cervix to the fundus. Now, when the different routes of administration were compared, what they found was that out of intramuscular, oral, and vaginal, only with the vaginal route, the endometrium was in phase in most of the cases, with oral not at all, in intramuscular with less number of cases. Though most of the studies seem to show that intramuscular, vaginal, and rectal have equal efficacy, but there are certain limitations of the intramuscular route. We know that they are oil-based injections. Patients are so reluctant to take them. Sometimes you have allergic reactions, and you also require a nurse for administration. So this is not a route that most of our patients seem to prefer. They are always cribbing about it. It's not that the vaginal route is, the end all of all problems. There might be certain concerns with the vaginal route as well, and some women may not prefer that either. They may either be reluctant to insert it, especially if there is spotting after a positive beta HCG. Some of them might have some irritation, although these things can be overcome by asking them to either change the vaginal formulation. Some are comfortable with one, some with another one, and also by, teaching them basic hygiene, asking them to use panty liners, etc. So out of all the different routes, the vaginal does seem to have its advantages. It's more physiological and it prevents the side effects with the oral and the intramuscular route. Out of all the different vaginal, preparations, they all seem to have an equal efficacy, whether you use a pessary, a tablet, or a gel. Now, what about dydrogesterone? Since we said that micronized progesterone cannot be used orally, but dydrogesterone can be used orally, right? So it does seem to have that advantage. It is potent, it has a much higher bioavailability, and it has other advantages like non-androgenic, non-estrogenic, non-corticoid, and it also does have an immunomodulatory role. The two trials that we all know about, the Lotus 1 trial and the Lotus 2 trial, did prove beyond doubt that it was at least as effective as using vaginal pessaries and vaginal gels. So it does seem to be a convenient oral route with better tolerability. But yes, there were some concerns about epigenetic effects and congenital heart disease that did discourage a lot of us from using it initially. Though later on it was shown that those congenital defects may not necessarily be related to the dydrogen molecule itself. Other problems are that it does not have as much an in-phase endometrium as vaginal micronized progesterone, and also vaginal progesterone but not dydrogesterone seems to improve the placental circulation as seen on color Doppler indices. And what about aqueous progesterone? Because intramuscular, we already saw it comes with a lot of side effects. People are not keen to take it, but aqueous solution can be taken subcutaneously. So it is more promising for, especially for women who don't want to take it vaginally due to various reasons. The studies show that with the aqueous progesterone has the similar ongoing pregnancy rates, live birth rates, and take-home baby rates as compared to vaginal progesterone. So it does offer a much more promising option, especially for, and it is also patient-friendly. Women can inject it themselves. Doses of 25 and 50 milligram are both equally effective. So the lowest, efficient dose, that is 25 milligram, is usually used. So when we talk about individualizing the route of progesterone, what should be considered the optimum route? There are so many routes available. In the end, it comes down to the patient preference, because everybody is going to have, some will be comfortable vaginally, some will just not want to insert it vaginally, though yes, vaginal is the most commonly used route. Now, when do you start the luteal support? Some started on the day of egg pickup. Some started a little later by the day of embryo transfer. The logic is that you've already given an HCG trigger, so there will be some endogenous progesterone secretion. It does not seem to matter. A window of time exists, and it's best to start it within 24 to 48 hours after oocyte retrieval. When this survey was done with almost 40 countries, almost 3 lakh cycles were included in this 40 different centers the surveys were sent to. 80% of clinicians said they started it on the day of egg collection. So even though there is no consensus as such, but in practice, yes, that is the most common time when you start it. And now what about the optimal dose? Again, because there is no consensus on the minimal mid-luteal progesterone level required for adequate luteal support, the optimal dose is not identified, but vaginally, most studies have used 400 to 800 milligram, intramuscular 50 to 100, subcutaneous, as I said, 25, and oral dydrogesterone mostly in the dose of 20 to 30 milligram. And for how long do you continue it? Actually, most studies seem to indicate that after a positive beta HCG, or certainly after the first ultrasound, there is no benefit of continuing it. But in practice, most of us do continue it till 10 to 12 weeks till the placenta has taken over. This was another survey sent to about 39 countries, and where most of the people responded saying that they started on the day of the pickup, they continue it till at least 8 to 10 weeks. Vaginal, most of them preferred HCG, almost nobody was using, and 5% did use subcutaneous alone, some used oral alone, and some used intramuscular alone, though vaginal was the most preferred route. Now coming to the other conditions, like what about estrogen? Some people add estrogen in the luteal phase. When exactly is that required? Initially, there were a lot of studies. Some seem to suggest that the success rates were equal, whether you add it or not. Cochrane database review said that there was no point in adding estrogen. It did not increase the live birth rates. But then when a further study was done, they did find in this large meta-analysis that initially they found there was a benefit of adding estrogen. But when a subgroup analysis was done, it was shown that in a GnRH agonist protocol, there was a significantly higher clinical pregnancy and ongoing pregnancy rate. But in a GnRH antagonist protocol, there was no difference. So probably in an agonist protocol, we might think of adding it. Otherwise, it is not required. Now you come to the other situation where you might require individualization. That is when you use a GnRH agonist trigger. Now what happens in the natural cycle when this LH surge takes place, it lasts for about 48 hours. Even when you give HCG, the activity spans several days into the luteal phase. But when you use a GnRH agonist trigger, there is a sharp increase and a sudden drop. So the luteal phase is much more defective. In fact, studies have actually shown that when you use agonist for trigger, you do have a markedly decreased ongoing pregnancy rate and a much higher rate of early pregnancy loss. So what do you do in such cases? You need a much more aggressive luteal phase support. There are two approaches. When the American approach, they ignore the corpus luteum completely and they give exogenous steroids. So they give higher doses of progesterone. Sometimes intramuscular is used. Transdermal estradiol is added. This is one of the situations where you would want to add estradiol. And you can assess the levels of estradiol and progesterone after 3 and 7 days. Ensure that the levels are maintained. Progesterone more than 20, estradiol more than 200. The European approach, on the other hand, aids the corpus luteum. So how do we do that? By utilizing HCG, either in the form of a dual trigger or you use low dose HCG 1500 units on the day of pickup or during the luteal phase. You can use daily low dose recombinant HCG or even recombinant LH. So when all these approaches are tried, you could do a fresh embryo transfer and hope for achieving similar pregnancy rates as using an HCG trigger. But in practice, of course, if we are using a GnRH trigger, most of us prefer to do a freeze-all cycle rather than taking a chance. Now, coming to the FET cycles, what happens in FET is that if it is a natural cycle, there will be an endogenous progesterone being released. So the luteal phase support required is not that obvious, but in an HRT cycle, that is a non-ovulatory cycle. There is absolutely no ovulation, no corpus luteum, no endogenous progesterone. And here the luteal phase support is so mandatory, it has to be fully supported, not just supplemented. So what have the studies shown? That as opposed to a fresh embryo transfer, when you are doing a frozen embryo transfer, the success rates, the live birth rates are much higher when you use a higher vaginal progesterone dose. Like say normally you would have used 600 to 800 in your fresh embryo transfer. In a frozen embryo transfer, studies show that going up to 1200 milligram per day will increase your live birth rates as opposed to using the lower doses, or you could add vaginal plus intramuscular or a higher dose of vaginal. Even when crinone gel, the study was done with using vaginal progesterone gel, and compared to using it once daily in frozen embryo transfer cycles, when it was used twice daily, the outcomes were much more significantly better. Now, we were talking about adding GnRH agonist for luteal phase support. There are 3 levels where it might work. It induces LH secretion in the pituitary, which supports the corpus luteum. It has a direct effect on the endometrial receptors and a direct effect on the embryo, aiding in implantation. So the studies have definitely shown a benefit, but the safety still needs to be established because large-scale studies have still not been done. These are the different ways that it is used. 0.1 milligram triptorelin given once a week after the egg pickup, or it can be given on alternate days for 5 days, or buserelin spray can be used daily for 14 days. And all these have shown much higher live birth rates and ongoing pregnancy rates and even decreased abortion rates. Now, there was this very interesting study which in fact showed that when GnRH agonist was used as compared to vaginal progesterone, higher live birth rates were observed in the group where only GnRH agonist was used. But then these studies are much more recent, and we have not yet extrapolated it and started using it for everyone because more studies are still required. Coming to other agents, adding prednisolone, most of the studies have shown it does not benefit. It's the same with use of aspirin. Now, heparin is a very promising molecule because it decreases the risk of thrombosis, and we know the hormonal treatments we give can increase the risk of microthrombosis. Heparin also aids in implantation at the molecular level, so it is a molecule which is used very, very commonly, though the evidence does not seem to completely support it, because if you see these studies, no evidence of thrombophilia. First IVF cycle, they did show that there was an increase in implantation, clinical pregnancy, and live birth rate, but it was not statistically significant. And then this other more recent study which showed that in women without thrombophilia, there was no effect on pregnancy rates. So currently, to justify its use for all cycles in clinical practice, multi-center trials are still required before we can do that. And lastly, coming to luteal phase support and IUI, do all IUI cycles require it? Most of the studies seem to suggest that when oral ovulogens are used, adding progesterone does not really benefit the outcomes, but when gonadotropins are used, there is a definite benefit seen. So when you do your IUI with gonadotropins, that is the time where you would want to add luteal phase support. So to conclude, we know that progesterone is an important hormone for gestation. It prepares the endometrium. It has immunomodulatory effects. It relaxes the uterine musculature. It is necessary to optimize the results of ART because in ART, the corpus luteum is otherwise deficient. Progesterone and HCG are equally effective, but progesterone is safer, so it is preferred. Orally, micronized progesterone doesn't work very well, so the parenteral routes are preferable. Intramuscular has its own set of side effects like being painful and causing abscess formation. So vaginal has become the most commonly used route worldwide. Micronized progesterone has a solid evidence of efficacy and compliance. It is more cost effective than gel when you use capsules, but then depending on patient preference, some might prefer to use gel because it has an ease of insertion and less irritability. Subcutaneous has now been proven to be an effective alternative to vaginal or intramuscular. There is no difference in clinical pregnancy rates when you start it on the day of pickup or in the next 3 days. There is no consensus regarding when you should stop it. We usually continue it till the end of the first trimester. Adding estrogen to progesterone needs further evidence. GnRH agonist trigger needs additional luteal phase support, and there is no evidence to support co-treatment with add-ons like aspirin and prednisolone, though the addition of heparin does have theoretical benefits, but then larger studies are still needed to decide whether all patients would require it. Thank you.
Thank you, Dr. Sulba. It was elaborated talk on very uh, controversial topic of luteal phase support. You covered everything with all the evidences, guidelines, and surveys. Thanks a lot. Thank you so much.
So here I would just like to add on individualized luteal phase support. This is basically for ART cycles, wherein you should do your progesterone levels either 24 hours before your embryo transfer or on the day of embryo transfer. So depending upon your progesterone levels on that day, you can alter your progesterone dosage. So if you find that your progesterone levels are less than 20 nanograms per ml, then probably you need to have an additional luteal phase support apart from whatever you're giving. And if your levels are between 20 to 30, that's optimal. It's also said that if you have levels above 30, again, it's going to reduce the pregnancy rate, which was also cited by Dr. Durusha in her talk, where she gave the various progesterone levels in the luteal phase and how they influence the pregnancy rates. The other thing we must remember that if you're giving oral dydrogesterone for luteal phase support, there's no use of measuring your progesterone levels because it's not a pure progesterone. Basically, it's a synthetic progesterone and it's not going to give the optimal levels, whatever is required in your blood. And we must also remember that if you're using intramuscular progesterone, then your levels are going to be higher. Though initially it was said that vaginal progesterone is the best form. Now there are several papers which have said that probably moving on to intramuscular progesterone gives better results than really vaginal progesterone, because if the pessary is not inserted properly and if the absorption is not proper, then you might not have adequate levels. So basically, the luteal phase, depending on the progesterone levels on the day of your embryo transfer or 1 day prior to embryo transfer, is going to determine your future luteal phase support. And that is a very important point that everybody needs to take home.
Thank you, ma'am.
Thank you, ma'am, for your guidance on progesterone level. So now, shall I invite our next speaker?
Yes, ma'am. Yes, ma'am. Please.
Yeah. So we are having our next speaker, Dr. Parikshit Nang sir. He doesn't need any introduction. Dr. Parikshit sir is, can you make it full screen, please? He is eminent speaker and treasurer, FOGSI, consultant Ashwini Maternity and Surgical Hospital, and sir is associated for ART at 16 centers in India, and sir was chairperson Safe Motherhood Committee FOGSI 2014 to 17, and he is postgraduate teacher and examiner, and sir is examiner for the MRCOG Part 3 as well, and had been awarded for Bhaskar Rao Gold Medal Award, Kamini Rao Yuva FOGSI Award, and over 100 peer-reviewed publications in index journals, and co-authored many books. And sir is going to speak on manipulations of hormone, and that is very important topic to understand. So over to you, Dr. Parikshit sir. Sir, you're muted. Sir, please unmute. Sir, you're mute. Yeah.
Okay, now I think it's done. All right. So, yeah, thank you so much, Dr. Tiwari. Always a pleasure to be introduced by you. I must convey my thanks to ICOG and especially Dr. Meenu Agarwal and Dr. Madhuri Patil for the kind invitation to be with all of you today and share some thoughts about a topic which is indeed very close to my heart. That is pre-IVF synchronization. The same talk is addressed in many ways. Some people call it pre-stimulation hormone manipulation. Some people call it making a batch. Some people call it pre-IVF synchronization, etc., etc. So first, let's understand and try to find out what we are aiming to do, and then how to do it. So that's what always reminds me of Kipling. He had this lovely quote which says, "I keep 6 honest serving men, and they will always teach you also what to do, what and why, when and how, where and who." So let's look at the first very important question as to what is this pre-IVF synchronization, or why do we want to manipulate hormones at all before doing an IVF cycle? So altering the spontaneous menstrual cycle to fit into a predetermined schedule for doing ART is what is synchronization. And when you do it for more than 1, 2, 3 patients together, then you call it making a batch or batching. Why should cycles be programmed? What's the need to do that? Because you want to make a batch and increase the efficiency of your workload. You want to avoid weekends and holidays as per your schedule, as per the clinic schedules. Because we also like to go out. We aren't robots. We need to do other things in our lives too. Avoid congestion. If it's a very busy center, you don't want too many OM pickups on one given day. You don't want too many embryos crowding up your your systems, and therefore you need to do this. So the top question is, why should you consider doing IVF in batches at all and changing the menstrual cycle as opposed to a continuous? So the reason why Jaideep and I started doing this was very simple. I mean, our lives were getting too complicated. We used to have too much travel. There were too many batches, too many centers to look after. And a number of them were outside Mumbai. We came to a conclusion that we need to make our lives much more predictable. Our unit was doing IVF somewhere or the other almost every day of the month. And we needed to know which flight to take and go where. And that's the simple reason why we started doing batch IVF. It led us to many other important conclusions too. And this is something which I always like to reflect on. This is data from 2013. This is the National ART Registry, all self-reported data. And I would like to draw your attention to this orange colored box at the bottom of the map. If you notice, a huge majority of centers are doing somewhere around 50, 100 cycles a year. So this is not a large clinical load. It doesn't justify running your IVF program every day if you're going to have a patient coming only once in 3 days, once in 4 days, once in 5 days. It does not make sense. You would rather concentrate them into one batch or one group and give them the best. Also, there is an abundance of gynecologists. I can see around 170 gynecologists logged in, but there is a big dearth of skilled embryologists. I mean, even if you ask me today, how many people can do a really technically proficient ICSI in a city like Mumbai, it would be maybe on the fingers of 2 hands, not more than that. There are many people who claim to do, but I'm talking realistic. So considering these factors, we thought that batching is not only to make our travel and our lives predictable, it's also important because it is neutral to pregnancy rates and clinical outcomes. Same number of people are going to become pregnant. It optimizes human resource. It gives you an economy of scale because your usage of media, your ordering, all this becomes streamlined. As I said, it becomes a focused activity, and an organized plan can be given to the clinic, to you, that's the personnel, as well as to the patient. Because if you have people who are traveling from abroad or traveling from outside the city where you're practicing in, then how do you manage that? I mean, the cycles are so unpredictable sometimes. The other very big advantage or very big plus point, what we noticed with batching, is the opportunity to mentor young gynecologists who are just starting their careers. Because when you teach somebody how to do an ovum pickup and you have one pickup on Monday and then the next pickup comes on Thursday, the learning curve is so much steeper. Whereas if you are going to do 8 or 10 pickups on one given day, the absorption of knowledge and skill enhancement is much faster, much better in these kind of situations. So for all these reasons, we consider batching as a standard practice. How do you make a batch? And that really comprises of 3 steps. That is understanding ovarian stimulation, what are the programming agents, and the logistics which go around making a batch. The first and most important thing is logistics, especially when it involves travel. They say amateurs, they'll discuss tactics, but professionals will discuss logistics. And that's why you've got to keep a sharp eye on this side. It brings us to what are the downsides or the perils of batch IVF. There can be a single event malfunction. Your travel plans may go wrong. Therefore, having backups, your alternate plans, etc., that has to be in place. Ovarian stimulation, this is what the standard protocol looks like today. You're going to start from day 2, day 3 with a sonography and stimulation with FSH or HMG. You give your on day 6. Standard protocol, but this is what basically it looks like. We know that there's no great clinical difference between agonists and antagonists, and gradually, except for certain niche indications, agonists, I believe, have become obsolete in the ART world. Antagonists also give you the chance to have shorter cycles, lower risk of ovarian hyperstimulation, fewer injections, lower gonadotropin usage. So how do we achieve a match? What are the programming agents? The desirable properties of a scheduling agent should be that it should be safe, it should enhance or be neutral. If you're doing day 5 cycles only in a fresh batch, or if you're doing an all phase, then you use whatever you like as a scheduling agent. It's not going to make any difference at all, because all the effects of scheduling agents are on the endometrium. There are hardly any effects on the oocyte performance. It should be economical and feasible, and it should be predictable, giving you effective program. If I look at my practice, a huge proportion, I would say maybe 90-95% of the cycles that I do are with oral contraceptive pills. A few are with estradiol, luteal phase estradiol, and just maybe an occasional patient, I might use antagonist for program. Lot of talk about reduced pregnancy rates with oral contraceptive pills. And this is Greisinger's meta-analysis, which showed that there was a decreased probability. But that's not the whole story. The whole story is that this was a meta-analysis which was too heterogeneous. There was very low numbers which were included. There were more than half of them had only 30 patients or less per arm. Different types of OC pills were used. Duration was different. And most important, the pill-free interval. That means the day you stop the OC pill and the day you start stimulation. That interval which is there, that was also variable in all the studies. Now we took a step back and went into ovarian follicular development when OC pills are stopped. So this is knowledge which comes from contraception, isn't it? We have a 7-day pill-free interval when we prescribe contraceptives. What's the genesis of that number 7? Why not 6? Why not 8? Why not 10? Because 7 gives you that optimum balance of achieving a menstrual period and at the same time not being too prolonged where ovulation will start. So if you were to have a pill-free interval of 5 days, and this comes from Garcia Velasco in Fertility Sterility, now already an old paper of 10-12 years, no effect on pregnancy rates. Again, more detailed analysis of every parameter, including endometrial thickness, so on and so forth. If you have a pill-free interval of 6 days, no difference at all in the cycle. Some tips on using oral contraceptive pills. Pill-free interval is necessary, particularly if you are planning a fresh transfer. As I said, if you're not planning a fresh transfer, your policy as a clinic is to do freeze-all. It's okay. You can avoid doing a pill-free interval, no problem. 30 microgram estradiol should be there. You can't use a 20 microgram pill because you'll get breakthroughs. Progesterone, whatever content you like, is fine. Minimum duration, 14 days. Upper limit, no, there's no upper limit, as long as you stick to the principle of a 7-day pill-free interval. Let's come to the second choice, that is luteal phase estradiol. What it does is suppress FSH and it synchronizes the antral follicles. It's supposed to be more physiological than giving GnRH agonist, which is your standard long protocol, or using the oral contraceptive. And this is work which comes from Belgium, Blockheel's study, and the one by Cedrin Dunerin, which basically looked at 17-beta estradiol, 4 milligrams per day as a pre-treatment. And their outcomes were the number of oocytes what were retrieved. There was no significant difference. P-value remained. The p-value remained non-significant. What about pre-treatment with antagonists? Interesting concept, because if you need to just delay the things by a few days, 2 days, 3 days, and this concept is important in European countries where they are desperate to avoid weekends in terms of doing ovum pickups. And what they found is the pre-treatment group, in fact, had a slightly higher pregnancy rate than the control group when GnRH antagonist was used to delay the start of the stimulation. So there's a lot of personal journeys, experiences which have gone into this thought process, and that's how we've been able to translate the theory into practice. So once again, thank you very much for your kind attention, and I wish you all the best.
Thank you, sir, for a wonderful talk. Requesting the chairpersons to give their comment. Rita, ma'am, are you there?
Yes, Dr. Thank, I think you were wonderful as usual. And it's nice to hear, when OC pills are being thrashed left, right, and center, somebody coming, because I think this is the different opinions which really gather, and then sometimes some study comes out and then people will just thrash that just no way of giving. And I'm glad somebody like you who, and in fact even I am doing a lot of batch IVFs in our different centers, and that's where experience counts. And then yes, even we are using pills, and I think it's very good take-home messages that you gave as far as pills are concerned, and the right use of pills, the right pill-free interval, the 30 microgram, all these is what probably people would love to take it. And I think this was an excellent talk. Thank you.
Thank you, Dr. Bakshi.
Thank you, ma'am. May I please request you to introduce our next speaker, Dr. R.J. Patel, sir?
Parishit, then you can just answer the questions posted for you in the chat box because we are running out of time. So if there are any questions, you can answer.
I'll have a look and answer.
In case you're going to leave, I'll answer your questions.
I'm just seeing there doesn't seem to be any question at the moment, but if there is, I'll answer.
Sure. Thank you.
Thank you, ma'am.
Ma'am, can you see the screen?
No, it's not visible. I
Just
can't
give me a
see
moment,
anybody.
ma'am. Just give me a
Yes.
moment. Ma'am, till then, can you read the CV? I've sent it. I'll just see there's some problem. I've sent it on your WhatsApp, ma'am. Can you
Okay,
just start reading it? Thank you.
just. Yeah. Okay. Yes, so it gives me pleasure again to introduce Dr. R.J. Patel, Director of Sunflower Women Hospital, Ahmedabad. A lot of experience in IVF. I think all of us know him very well because he's also the expert committee in the Central Board for Art and Surrogacy Regulation Act, and we all keep troubling him whenever we are at loss as far as ART laws are concerned. President Gujarat Chapter ISAR 2426 and awarded the Best IVF Center 2012. Bharat Ratna Gujarat Se Award by Smriti Irani, member of so many and has delivered many, many lectures. I think we are all dying to hear Dr. R.J. Patel. Stage is all yours, sir.
Thank you, everybody. Good evening. I think I'm the last batsman, and 2020 final is going on within short time. We all the best to our Indian team. This is ART law is like test match, but I have to finish with 2020. This is a very hot topic about what we should know as a clinician to make our clinic hassle-free, litigation-free. We know this all regulation came to regularize the ART as infertility is rising and ART cycle is also rising. To regularize the ART clinic and ART banks and surrogacy, there is a regulation in 2021 December to make more smooth functioning, and it was needed to supervise all the regulation, licensing, smooth functioning of the ART clinic and banks. So in short, what is the ART clinic? One is for the IUI, maybe sperm, maybe donor IUI they can do. Minimum requirement is gynecologist, and gynecologist shall have medical post-graduation in obstetric and gynecologist. What is the requirement? That is a microscope, centrifuge, and refrigerator is enough for the ART1 level. Now, how to do registration? There is a portal. That is the National ART and Surrogacy Registry. You can go log in it and make the account and fill and submit the application. And after application, require fee you can pay for the ART1, 50,000, ART2, 2 lakhs, and ART bank 50,000. That is the fee for 5 years. So that your clinic will be inspected by the appropriate authority. They will see all the infrastructure, manpower, and your documentation. Then they will grant the certification for the 5 years. So again, we talk about the fees and all the requirement we will have to fulfill it. And this is the form 1, 2, and this is a registration certificate. That all registration certificate you have to display in your clinic, which should be visible to all your patient, and it should be in a conscious place and shall maintain the duration and validity of the such registration. Every 5 years, you need to further renewal. For the ART2, what is ART2? What is the IVF? It is a surgical egg or sperm retrieval, handling of egg or sperm outside the body and make the embryo. Whatever embryo is formed, you have to transfer in the woman in the reproductive system, and remaining embryo we can do cryopreservation for the further use. So all procedure related to ART to IVF related, you can say ART2 level clinic. What is the minimum manpower required is 1 gynecologist, 1 embryologist, 1 anesthetist, and 1 counselor. Additional staff may require is director and andrologist. What is the qualification of gynecologist? Should be medical post-graduation, should have worked 3 years in any certified clinic, and have minimum experience about 50 ovum pickup. And further, now instead of post-graduation, MCH, DM in ART, and fellowship is also can do for the further study. For DM and MCH and FNB, they not required to do 50 pickup experience, but at least they need 3-year experience under the any ART registered clinic. What about andrology? The sperm retrieval can be done by the urologist, maybe MCH or DNB, but because of too much required in the district place now, any general surgeon, maybe MCH, DM, FNB, have minimum 2 years of experience of handlings of this type of procedure and have special training in male infertility, and those who have minimum 15 surgical sperm retrieval, they can qualify for the surgical sperm retrieval. That is a andrology. For embryology, special courses available after graduation, post-graduation in clinical embryology, further study in PhD in a subject of embryology, medical graduate like MBBS or veterinary graduation, all or post-graduation in life sciences or biotechnology. After the degree, they need to do work about the handling egg and sperm, about the embryology work in any qualified ART center. And they need to have experience of at least 50 IVF lab procedure. That is a IVF, maybe ICSI. And around 100 cryopreservation of the embryo. So experience plus procedure is required to qualify as an embryologist. For the counselor, we need any graduation in psychology, clinical psychology, even nursing staff can do counselor or life sciences. Anesthetist, again, medical post-graduation in anesthesia. For the director, post-graduation degree in medical or life sciences or management sciences. What is the minimum required? Microscope, minimum 2 incubator, laminar airflow, sperm counting chamber, centrifuge, refrigerator, equipment for the cryopreservation, ovum pickup pump, ultrasonography with the transvaginal probe and needle guide, test tube warmer, and anesthesia resuscitation trolley. That is the minimum requirement for the ART2 clinic. Here, simply IVF. They have not included even inverted microscope, that is ICSI. So even simple IVF is enough for the ART2 requirement. Now, what is the duty? They have to stimulate the patient, make the embryo, and use for the patients. Unused gamete or embryo, they have to use for the same recipient. They cannot use for the another person. Oocyte or sperm, whatever preserve of the onco patient, they have to preserve for the 10 years. After that, they need to permission by the national board. What about PGT? whenever it is pre-existing disease, genetic heritable disease, they can do PGTA. But whenever it is medically indicated, you can do PGTA. Like 2 failed, 3 failed, repeated implantation failure, you can do PGTA. Sex determination is strictly prohibited. So you have to make all the documentation about the pickup, about your embryo formation, about the embryo transfer, remaining embryo you have to do cryopreservation. So all form is available about the specific treatment. So you have to return consent, properly you have to inform. That is the main counseling, proper information, what is the success rate, what are the complication, what are the cost. You have to counsel a lot and make them more aware about the procedure. So what is the age limit about the ART? For women 21 to 50, for men 21 to 55. So all record you have to keep for 10 years about the procedure, about the indication, how many embryo formation you have done, how many you have transferred, how many remaining, how many trial you have done. That all record you have to keep for the 10 years. So after 10 years, you need permission by the national board. All clinics should retrieve ovum pickup with the safety of the patient. How many embryo you can transfer? Better to transfer single embryo to avoid any problem of the multiple pregnancy. But in difficult situation like repeated IVF pregnancy loss or residual milk factor, you can transfer 2 or 3, but not more than 3. Women should not be treated with the gamete embryo derived from more than one man or woman. No mixing during treatment cycle. You can never mix multiple male partner semen for the same procedure. Or you cannot split the embryo to make more embryo. So that is very important. What about donor? About semen, who can donate? Age should be 21 to 55. But for the women donation, egg donation, the limit of age is between 23 to 35. And we have to inform the donor, examine the donor about this. If it is male or female, you have to do disease, infectious disease investigation. One single donor cannot supply to more than one commissioning couple. So no egg sharing, no sperm sharing. Oocyte can donate her egg donation once in her life. And at the same time, you cannot retrieve more than 7 oocyte. But for to avoid the OHSS, whatever the form follicle is there, you have to retrieve to avoid the OHSS. But it should be to prevent the OHSS, mild stimulation. Make the soft stimulation. Egg should be around 7. But by chance, if it more than 7, all form follicle you have to aspirate to avoid ovarian hyperstimulation. But donor can donate only once in her life. Unused oocyte used for the same recipient, not for the another person. So that is very important about the donor. All the information about the donor, their mobile number, Aadhaar card, their address, information should be written consent is must. For the egg donor, we need to ensure the safety of the donor. They have to take the insurance, health insurance as well as life insurance for the 12 month. Whatever the any complication happen, that is the responsibility of the recipient couple. So therefore that we need affidavit against about the procedure. They have to take the responsibility of the donor for 12 months. Again, we have discussed about the PGTA whenever it is indicated medically or whenever it is known case of pre-existing disease, heritable genetic disease, we can do PGTA, PGTSR or PGTM. what is the restriction? The gamete or embryo, any part within India or directly or indirectly or outside India shall be prohibited except the permission of the national board. Any problem any patient is not satisfied, they have right to have complaint. For that, and all the ART clinic need grievances redressal. They have to make the box. Maybe your IVF center, 1 or 2 or 3 responsible person, maybe manager or any or medical officer, have a duty to address any problem. If they have not satisfied, they have right to give complaint about their problem in return. Now, what is the ART bank? Is responsible for the screening, collection, and registration of the semen donor and cryopreservation of the sperm. But for the oocyte donor, they have to maintain the record about the donor, egg donor. They have to counsel. They have to do all the record about the donor from the clinic, how many embryo form, how many they have transfer, and what is the result. And that all the information they have to carry forward to the national board for the further use. So for the ART bag, minimum 1 RMP, that is registered medical practitioner, is required for this handling ART bank, preparation and storage of all the semen or oocyte donor. So what is the equipment for the ART bank? Minimum requirement: centrifuge machine, incubator, microscope, and laminar air flow. So record you have to keep, and with all the form, you have to form, duly form, and you have to keep record for 10 years. What medical examination is needed for the donor? That is HIV 1 or 2, hepatitis B virus, hepatitis C virus, and treponema pallidum syphilis through the VDRL. So all infectious disease should be screened for even male and female both. What are the offense? Any problem related to information, record, or any handling in the donor, egg or sperm, or embryo sharing, or PGTA or sex transmission, there is a imprisonment initially with the money, maybe 5 lakh, 10 lakh for the first time. And second time, they can punish up to imprisonment. And third time, they can have right to cancel your registration. So you have to be careful about all the record and counseling and procedure. All the varieties of, you cannot sell the embryo, you cannot. This is the way you can avoid your any problem. But here in ART 1, 2 or ART bank, no court shall cognizable, or the complaint should not be done in the no inferior than the metropolitan registration or judicial registration for the first class. So it's a cognizable, and it can be have a cognizable. But in a surrogacy, it's a first offense. Not you can punish by the money, but directly imprisonment. That is a different. It's available and cognizable in ART 2, ART 1 or bank. All the procedure responsible, any procedure you have done in ART 1 or 2, your head is responsible. Except head has informed all the and taken all the precaution to avoid all complication, have qualified staff, qualified all the training, and by chance staff have done mistake, then the responsibility will be the staff. So that is a very important. So we'll not go in all the forms, affidavit required. Now few words about the surrogacy. So we know maybe commercial surrogacy is strictly prohibited. Only altruistic surrogacies we can do. We cannot give any charge, expenses, fees, remuneration, monetary incentive, whatever nature, except medical expenses or insurance or any transportation charge to the surrogate. We cannot give anything to the surrogate mother or her dependent or her representative. So that is very important. Only altruistic, willing women can become surrogate. Now, who is eligible for surrogacy? Infertile couple, Indian married couple, have medical indication for the gestational surrogacy. Women age should be between 23 to 50. Man age should be between 26 to 55. And they not having any child. If they have child but medically unfit, life-threatening condition, they need certificate by the district health officer. Widow women age should be between 35 to 45. Divorcee women between 35 to 45. Or Indian origin couple, OCI or PI, person of Indian origin, can do surrogacy. Who is not eligible? Single widow or divorcee man, single unmarried woman, living couple, LGBTQ intending parents, foreign couple, or those who have one child. Any healthy one child, they cannot do surrogacy for the second child. So, who can be surrogate mother? Even married woman. Age should be between 25 to 35 on the day of implantation. She should have her own child, and women should be willingly to do surrogacy, not necessarily relative. Willing women can do. Not to provide her own eggs, only once in lifetime. Maximum 3 trial you can do transfer. If 3 trial fail in one single surrogate, you have to cancel it. And surrogate have medical and psychological fitness by the registered medical practitioner and must possess an eligible certificate by the appropriate authority. Only for altruistic purpose, not for commercial purpose. Intended couple should possess certificate of essentiality by the appropriate authority, certificate of medical indication for the intending couple or woman by the district medical board, order obtaining the parentage or custody of the child, that is a birth affidavit of the child by the magistrate. And that is a main hurdle to do surrogacy nowadays. That is a magistrate certificate. Before birth, the magistrate court should give the birth of affidavit of the child. And insurance about the safety of the surrogate mother during procedure, during antenatal, postpartum for 36 months. So, no person shall conduct surrogacy procedure unless he has explained all the known side effects and after effect of such procedure to the surrogate mother concerned. Obtaining the prescribed form, written informed consent of the surrogate mother to undergo such procedure in the language. She underwent the surrogate mother shall have an option to withdraw her consent of surrogacy before the implantation of embryo. Couple undergoing surrogacy must have both gamete from the intending couple. But now some changes, district medical board can certify if there is any problem in egg or sperm of the coming couple, they can use egg donor or sperm donor, but not both. But indication from the sperm donor or egg donation should be justified. And you need certificate by the district medical board. At least one egg or sperm should be by the surrogate couple. What about single women undergoing surrogacy must have self egg and donor sperm to avoid the surrogacy procedure. Thank you very much for the patient hearing.
Thank you, sir. That was really very, very, very clear. I think I am quite dark. I am in the car. Madhuri madam, you can take it forward. But there was one question, single women who are only ever married can go for surrogacy,
No.
not single unmarried women. Yes.
No.
Right, sir.
Married couple only can do surrogacy.
Right.
Single women can do IVF with own egg, even donor sperm. They can do IUI, they can do IRT, IVF, but they cannot do surrogacy.
But surrogacy, divorcee or widow can do.
Yes,
Single
yes.
woman cannot do.
Yeah,
Yes,
yeah.
sir.
After marriage, if it is divorcee or widow, they can.
Or widow.
Or widow, yes.
But they have to then give their death certificate of the husband
Yes,
or the
yes,
divorce.
divorcee, all the receipt, all certificate they need.
Right, sir.
Yes.
Right, sir.
It was, I think it was a very crystal clear message. And I think if any of the attendees have any query, I think Dr. Patel is the best person to ask.
Sure.
So, if there are any questions, we can. So they're asking about the renewal of ART registration. And also whether, I mean, donor program and surrogacy can be done for divorcees with medical indication. The surrogacy, I think.
Yeah, medical indication for the surrogacy is absent of uterus, any hysterectomy, no absent uterus congenitally, thin endometrium, small uterus, or they are not medically fit for the cardiac or any reason, they can do surrogacy.
So they're also asking, can foreigners be allowed to use oocyte donor?
No, foreign couple cannot do. Foreign, two type. If they are person of Indian origin, yes. But those who are not person of Indian origin but foreigner, they cannot allow surrogacy.
No, they're asking about donor, oocyte.
Yeah.
Egg donor is allowed. Egg donor
Yeah,
is
yeah.
allowed. Surrogacy is not allowed.
No, surrogacy not allowed.
Egg donation is allowed.
Yeah, but it should be altruistic and they should know the Aadhaar card and number from the. So.
No, but some of them who are no longer citizens, who don't, because we really don't have a dual citizenship. No? So people who have taken citizenship of other countries, whether they are allowed
Donation, okay.
to undergo oocyte donation.
Yeah. Both
But
couple,
they
husband
have
and
the
wife.
certificate of, yeah. They have the certificate of Indian origin. So
Yes.
they overseas Indian origin. They are allowed, but they should have that certificate with them. Even if they have.
No, I think that was a
the other country.
No, I think, Meenu, that was a controversy because whatever meeting I attended with the secretary, the health secretary, they said that even those with what they have that NCR, what is that? I don't, NRC or whatever that card they have now. So even with
OCA.
that, they cannot undergo egg donation, any third party procedure. What is that card?
Madhuri ma'am, egg donation is allowed even for a foreigner couple or for a OCI, but surrogacy, your right, is not allowed for a foreigner, but surrogacy for OCI couple, if both are OCI, it is allowed. Am I right, Patel sir?
Yeah.
No, I don't think so, because at least at that meeting it was discussed and they said
but need
it's not allowed. I don't know. I mean, that's what it was saying, unless it changed.
But if they are both are OCI, they need special permission by the national board. They have to represent all the documents to the national board. They will see what is the exact situation of the OCI. A foreigner from outside India, they need special permission by the national board. Directly
Even
they
for
cannot. Yeah.
They cannot undergo.
Yeah.
Any other questions? I think most of the messages were crystal clear, and I think let's go with the post test, and then once that's done, we'll discuss the answers. Thank you very much, Dr. Arju Patel, for being here and giving.
I really had to chase him to give talk. Thank you, sir.
Thank you.
This wonderful, awesome talk, sir, by you.
Thank you, sir.
Thank you. So I think the post test link is already posted. So everybody can log in and give the post test for today. And then Madhuri ma'am, we will discuss, we will tell the answers for all the 3 days now. So Madhuri ma'am, we will tell the answers for all the 3 post tests
Yes.
today.
We'll tell for all the 3 days.
Okay. Yeah. So the post test link is already posted, so everybody can log in and give the post test now for day 3rd today. Yes. Thank you.
And Meenu, now we should not have the third post test once we give the answers on the website for people to answer. Whatever they're answering now, that should be done. Because we had kept it open, because then we are already giving out the answers. So I don't think it should be open on the website.
That's right, ma'am. Yes, I agree. I think the time is over now. And Nilima,
Yes, ma'am, the
Vedika
time is
has
over.
has everybody submitted? Are you giving them a grace time?
Yes, ma'am.
Okay. All right. Another 2 minutes we can give them.
Yes, sure.
Are you traveling somewhere, Meenu? Unmute, unmute.
Yeah. I'm traveling from Pune to Latur.
Okay.
So it takes almost for 6.5 hours. I started late because I wanted to give the talk with the good Wi-Fi.
Belinda George was also good, no? I mean,
Very good. Very
good.
good and very practical. Yes. Very good faculty.
No, I thought that's the best to give to an endocrinologist. So
Correct. 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 And she's done a lot of work in it. Dr. Gauri was superb.
yeah, she used my slides.
Okay. She mentioned that in the beginning, yes.
No, even at the even at the end, she mentioned.
So she was very, very good. Your slides were excellent also. So I know who to ask if I am in a dire need of slides now.
Yeah, most of them I have.
Thank you. So I think the time is over. Shall we just tell the answers? Day 1, day 2, and day 3. Madhuri ma'am, will you please go ahead? A lot of compliments from the doctors about the course. So I think Nilima, you can take a screenshot, Vedika, and pass it on to Dr. Sarita Bhale Rao for her ICOG report.
Yes, ma'am. Yes.
We have the first post test online, I mean on the screen so that we can answer.
Yes, ma'am. Sharing the first post test.
And Vedika, they also want to know how to get the certificates. So please also that also have to be, we have to tell them.
Okay, ma'am.
No, but I think they'll have to give all the 3 post tests to get a certificate. How is it?
Correct. Vedika?
Nilima? Nilima?
Ma'am, Nilima ma'am is not there. Just a minute. Poonam ma'am will come.
No issues.
Is the screen visible?
Yeah, it is.
This is the first post test.
Yeah.
So there are a couple of questions that we were little bit, they were little ambiguous. So we will remove those from the scoring.
Yes. They were not framed properly, so they cannot be used. Those questions, which we would not consider.
Right.
Just go slow now. You're going too fast for people to get the thing. One minute. That 7th question. Okay. Yeah, ठीक. I think the 19th question should not be 1 minute. Just show me the question 19. So basically, this should be how many cycles of IUI should be done So basically, you should not, it's the minimum number of IUS cycles for obtaining results. No, you can obtain results even in the first cycle, second cycle. So it is the maximum number of cycles that can be offered to the patient. So that should be this question, and it should be 3 to 4. Yeah.
Vedika, go for the next one now. Vedika, are we finished?
Yes, ma'am. For the first post test, it is done. Now I'll be
No,
sharing for the second post test and the
okay,
third post
sure.
test. Yeah, just give me a minute. I'll just share.
Sure.
Now, is it visible?
Yes, it is visible. Yeah, I understand some of your you go through the answers and you will know that whether you gave the correct answer or not. So you can also use it as a self-assessment score test.
I don't know why they have not corrected, yeah. Why they put it like that only, Minu? So basically 15, the correct answer is C, because AMH basically governs the recruitment of the follicles. So it basically prevents the recruitment of the pre-antral into antral follicles. And it does not play a role in selection of dominant follicle. So the correct answer is C for 15. Estrogen and fibroid is because you're giving GnRH agonist now, so they might develop menopausal symptoms, so you can give low dose estrogens. Yeah, I can scroll up. So basically this question should be there because none of them are correct. So we are not going to include this when we are going to give the marks. And even question 24, we won't include because basically the older, none of this holds true for whatever the question has been put up.
Ma'am, for the day 2 MCQs, post link, the MCQs are done. Should I go for the third day MCQs?
27, they're saying the answer is wrong.
27th.
Can a single woman opt for surrogacy as per Surrogacy Act? No, she cannot. So she cannot go for surrogacy. So this answer, no, is correct. Yeah, you can go for the third day.
Yes, ma'am.
This I'm not seeing, so I don't know. Answer 21 also, it is basically 2 milligram twice a day from day 16 to either day 25. You should not use it till day 1 of menses because you will not have, you will not get a withdrawal if you use it for that many days. So basically it should be 2 milligram twice a day from day 16 to day 25. So basically after estrogen priming, there'll normally be a gap of 3 to 4 days before the patient will get her periods. Because it takes time for a patient for withdrawal once you stop the estrogens. So you will not, 24 hours is not the right answer.
Ma'am, we are done with the 30 questions.
Yeah.
Yes.
So I think there was some deficiency on our part because I think all the questions were not checked. I mean, whatever were checked, we have done the thing, but many of them were not checked and therefore probably are not right. And some questions were not properly framed, so the answer to that could not be given. So I'm extremely sorry for that, and probably we would correct that in our next course, whatever we do. And I'm sure all of you all would have enjoyed and had a lot of take-home messages from these 3 days. And probably you would use these take-home messages in your practice because there's no use of just listening to them and going back and doing the same thing what you were doing. So I think listening and going and implementing them in your clinical practice is basically the motto of having these certificate courses. And I would also request Meenu to give say the last words.
Yes, yes. Thank you, Madhuri ma'am. It was excellent to, this is the first time I did a course together with you. It was so nice. And I'm sure, as Madhuri ma'am said, all the delegates who joined in, and I'm very happy that all 3 days they were all logged in, they were asking questions, they were interactive. And I'm sure you must have taken a lot of take-home messages. And anytime you have any questions and you want to interact with the faculty, I mean, I'm sure you can make a personal request. I'm also always available, and you can just WhatsApp
Anytime you
message
can
me and
ask.
ask.
Yeah, so
Yes, yes.
email is a better way of asking, but you can also ask on WhatsApp. That doesn't make a difference.
Yes, right.
Always
And
available to answer all the
uh,
questions.
and Madhuri ma'am, you are superb. I mean, I don't have words to say to you, because she actually, you also checked all the questions, all the answers, and the deficiency was with me, that I did not put the corrected ones which you sent to me, a few, 3 or 4 only, but rest all question and answers were given by the faculty, and they and also by Madhuri
No,
ma'am.
but I think
So
we
thank
should
you.
check them once. I mean, who are the conveners? Because I think that's very important.
Right, ma'am, right. And a big thanks to Dr. Sarita Bhalerao, Secretary ICOG, Dr. Parul Kotlawala, Chairperson, Chairman ICOG, and of course Dr. Jaideep Tank, President FOGSI, and Dr. Madhuri Patel, Secretary FOGSI, for giving us this opportunity to conduct this
So, I
particular
mean,
3 days online.
if they can mute the
Yes, ma'am.
of the participants, if they want to give us a feedback, it would be very nice. So if you can tell these people to unmute, whoever wants to, they can raise their hand and we can unmute them, so that when we do our next course, we can include those changes, whatever are there, what the delegates feed.
So if you want to, you can just raise your hand, and Vedika will unmute you.
Raise your
Vedika
hand
will
and
unmute
we will
you.
unmute you, so that we would get to this thing.
Yeah, anybody wants to speak anything, just raise your hand. I mean,
Please
there is an icon of raising your hand. There
Please
is an
unmute
icon there of
Aradhana.
raising your hand.
Yeah.
Hi, ma'am. I'm really grateful to you that you have conducted such a, genius this course. And although there was few confusions, but I think you have made everything corrected. And the very good faculty, and it's a good compilation of topics, but it's still, much more we want to listen. And I'm really hopeful to have one more course for the remaining topics, because as somebody was asking about the PC is a huge topic, and it's a very common, commonest, what we are getting in OPT. So I think we want to listen more about such thing. Poor ovarian reserve, again, it's a very, it's a quite common nowadays. So we would like to listen few more, words from you. And you are to like a book in itself. You are a library, I would say. So you have, so many PPTs. I heard yesterday that you have thousands of PPT. It's really, yes, whenever I listen to you, your basics are so wonderfully. You have, mastered all the basics. I have heard many a times.
One should just know the physiology, both in the male and the female. And that will, that's why whenever I take the ICOG classes for the students, I say that I'm going to take the physiology, because I understand the physiology. But
And
people
every time
don't
you take
understand
physiology in such a wonderful way, and all the endocrinology in every part. Not only that, all the chemical level, receptor level, everything you have mastered. You have conquered everything. I would say.
nothing
You
like
are
that.
king of infertility, queen of infertility, whatever you just say. And this was wonderful. It was mesmerizing. It was mesmerizing. You couldn't get up from your seat once it starts.
For me, learning and teaching both is a passion. I had such good teachers that has imbibed in me that teaching is should be done, because whatever you know, you should impart. So my teachers, I
You
owe
are a very
everything.
honest teacher. You are a very honest teacher. You
I owe everything to my teachers, basically, who have inculcated in me that I should teach.
You must
So
have been a favorite student of them.
no, not that. But people don't like me because I'm quite a khadus teacher. Exam.
I think this what you are saying, Khadus, that is, the wisdom you are doing, because you are not manipulating the things. You are very straightforward, and I like that in you. You don't get carried away by somebody else because or she is the senior, or you think she's the giving talk, but you just stay forward. You just say, no, this should not be given, pass on to, people who are listening.
But we should pass the right message. That's what is my motto. I mean, that's what I feel.
And
It's
that's
right.
very true. It's, unless we have a proper study for something, we should not, pass this, whatever we are doing or what we are learning from our experience. Because nowadays, everything
No,
is
because one thing
pattern
what I
based.
want to tell is all of us, we say, okay, we've just treated up 5 or 6 patients and we say, oh, this, we've got results. It doesn't work like that. So to have evidence, we have to have a randomized control trial where you've not given, you've given. And then we need to compare the results. And then only we can say that it is effective. So that is lacking in our Indian doctors because we have so many patients to see and probably we don't have really time and we are not trained during our college, to do these type of studies. Like I being an editor for the ISAR journal for 13 years, and now I'm with fertility sterility of ASRM. So, I mean, I've been inculcated with the statistics as well as what a study should be. And therefore, probably I'm outspoken and I say that this is right and this
I
is.
remembered a webinar in which Madam Kamini Rao was, she was about to give another talk. Just before that, you have given the talk. And under the physiology, you have taken everything. Then Madam Kamini Rao has said, Madhuri, you have taken my talk too. Now you take my Padam Shri too. It was really, because you have talked so well. I mean, you have not left, few of the slides. There was so much of overlapping slides after that. But you were so wonderful. I mean, in your talk, I heard the physiology you have given in such a wonderful way. And it's really, a feast to academic feast when I listen to you. So it's you are really truly an inspiration for all of us. And I'm taking FOGSI infertility courses since 2013. So it's more than 12 years, and I too have so many students, and you are truly an inspiration for me. That you should start from the basic. This is what I have learned from you. I mean, some people they just teach the ovulation induction protocols, this and that, but I think basic is a must. Without that, you can't stimulate your patient. That's a very good message to all of us.
I think the other 2 people, Smriti and
Anyone
Bhuvan.
else wants to say something? Yeah. You can
Smriti
raise your hands and say, yeah.
and Bharti. Can you unmute them? Bharti, Smriti and Bhuvana. Can you unmute these people? I think they've unmuted. You can just unmute yourself. Bharti, can you unmute? Vedika, can you please unmute those 3 people who have raised their hands?
Hello? Yes, ma'am, I did.
Yeah.
Hello?
And also Smriti and Bhuvna. Yeah, Bharti, you can go ahead.
Good evening, everybody. Indeed, a very good, fantastic sessions all the 3 days. I missed the first one and I'm the loser. And congratulations to the ICOG team, FOGSI. Madhuri ma'am, you're really an encyclopedia. Meenu Agrawal madam conducted very nicely. And definitely this is going to help us in our practice and we'll make the changes. Wherever we are making mistakes, we are going to rectify them. A big, big thank you. Always indebted to the whole team, especially to the teachers, Madhuri ma'am and Meenu Agrawal ma'am. Thank you so much. Superb. Hats off.
Thank you. Smriti.
Thank you very much. Thank you very much. Thank you.
Hello.
Hello.
Dr. Madhuri, it was a wonderful session by all the teachers. I would request specifically Madhuri ma'am, can you take some course like this, a short course on ovulation inductions and physiology? Because there are so many protocols going on, it's so confusing. And I think you people are so used of doing IVF that people speak so fast. Maybe because the way your funders are so clear, I would really request if you could make some course just for ovulation induction protocols and the basic physiology behind it.
You can arrange and I will do it.
Thank you so much.
Hello, ma'am. Good evening. Thank you so much for the wonderful session, ma'am. For 3 days, all the speakers were excellent. They're informative. They're very precise, excellent in whatever they're telling. And it is really our privilege to have such kind of teachers. Even though online we haven't spoken anytime, seen anytime, but it's great to have such a great teachers, ma'am. I have one doubt, ma'am. I tried to ask in chat box, I couldn't reach you. In one of the options regarding hysteroscopic myomectomy, one of the option was giving GnRH for 10 to 14 days.
Yeah,
Giving for
that is just to reduce the blood supply, so your dissection will become easier.
So giving for only 2 weeks,
But
still
now
we
there's
can
a
see
lot
the
of
effect, ma'am?
controversy on that.
Give it
So
for,
some
yeah.
say that probably, it makes your dissection feel, I mean, it's not well defined. So many people do not give, but it definitely reduces your bleeding. So, I mean, there are two schools of thought. Some believe that it's useful, some believe that it's not useful.
Yeah. Also, if you're doing a hysteroscopic myomectomy and it's a submucosal fibroid more than 4 centimeters, that is where you can give GnRH, but give it for 3 months. And that will reduce the size of the fibroid, and then you can go hysteroscopically. However, if you have to do laparoscopic myomectomy, then it really does not help reducing the size of the fibroid because you lose the planes. It becomes a little difficult to do it laparoscopically after GnRH agonist.
Yes, ma'am. Just I wanted to make sure giving for such a short duration, will that be
At least for
helpful
3
and will
months.
have any effect on myoma?
No, at least for 2 to 3 months. You give depot dose every month for 3 months.
Okay, that's clear. Thank you so much, ma'am. Thank you so much, each and everyone, for the session. Thank you.
So if we have no more comments, I think, Meenu, you can do the last vote of thanks.
Yes. Yes. So thank you very much once again, everyone. All the delegates who joined and who gave such good comments. Thank you, FOGSI. Thank you, ICOG, Dr. Sarita Bhalerao, Madam Dr. Paru Kotlawala, sir. And thank you, Madhuri ma'am. Very nice. It was so wonderful to not just to interact with you, but to listen to your talks and to see your slides and to listen to every comment that you gave during these 3 days. So thank you very, very much. And we will wind up now, and then we shall see each other again in person, all of us. I'm sure we will meet sometime somewhere again.
Yeah, so basically, somebody who wanted to know about poor ovarian reserve, the ISAR is going to have a masterclass on poor responders, which would be in Hyderabad, and we are having one of the main persons who's been a part of the Poseidon group, who would be coming to us. So we would announce those dates. So I think all of you all will definitely benefit. It's going to be a 2-day masterclass on just on poor responders.
So yeah, Aradhana is asking what are the dates.
We'll just tell you the dates because that Mr. Carlo Albeti was not available in the last week of November. So we are just looking at the other dates and then we would inform what the dates would be. So I think we can log out now, Meenu.
And yes, and thank you to Vedika, thank you to Nilima, Jignesh, or the entire ICOG team. They are working beyond their working hours to conduct this course. So thank you very much, the entire office staff, for all this coordination. And Sandhya, Samita, and Srishti. These 3 girls have really worked very hard coordinating with all the chairpersons and the speakers on all these days for the last 2 weeks. So,
okay.
Many compliments. Fantastic. Thank you.